outside the bicipital groove. There is joint effusion along with posterior subluxation of the humeral head in relation to the glenoid. Patients with glenohumeral instability can be managed non-operatively through physiotherapy or operatively. Physiotherapy remains the mainstay for managing Stanmore triangle polar type 3 instability arising from muscle patterning. It is advocated in most first-time dislocators, in the initial management of multidirectional instability, as well as in patients not keen on surgery. Operative management of acute anterior instability is mainly reserved for first-time dislocation in a sports person. Current standard for operative care in the acute setting is arthroscopic Bankart repair. Usually 2 to 3 anchors suffice if good repair with adequate capsular and ligamentous shift is achievable. Arthroscopic stabilization works well in most low-level sports person and the general population, even with some glenoid bone loss of around 15%. Having said this, surgery is generally tailored to individual needs. In operative management of chronic instability, there are two key questions. What is the problem? Is it soft tissue, bony, or both? If bony, where is the problem? Does it involve glenoid, humerus, or both? Glenoid bone loss reduces the contact area between the humeral head and glenoid. As a result, dislocation can occur more easily in a downward spiral, with easier dislocation leading to more glenoid bone loss, leading to more dislocations, so on and so forth. This is the list of some of the studies performed to evaluate accuracy of arthroscopy, radiography, 2-dimensional and 3-dimensional CT, as well as MR imaging to quantify glenoid bone loss. CT measurements of glenoid bone loss show generally good correlation with arthroscopic measurements. Due to anterior obliquity of the glenoid, it is difficult to judge glenoid bone loss on axial CT slices alone. 2-dimensional double oblique reconstructions and face to the glenoid for both dislocating and non-dislocating shoulders are performed to evaluate glenoid bone loss on the affected side. These reconstructed views show severe bone loss as concavity of anterior glenoid line on the affected side when compared to the normal convexity of the anterior glenoid line on the unaffected contralateral side. Now let us see how CT measurements are actually performed. On these end-phase reconstructions of both dislocating and non-dislocating shoulders, the long axis of the glenoid, also known as sellar line, is delineated. Glenoid width is measured at right angles to this long axis at the mid portion of the rounded inferior two-thirds of glenoid. Glenoid bone loss is calculated as the difference between the width of the affected glenoid and the non-affected glenoid. This gives more accurate assessment of the degree of bone augmentation needed to stabilize the shoulder, as glenoid width of the non-dislocating shoulder acts as a personalized reference point. This method is only possible using CT scan, as non-dislocating shoulders are not evaluated using either MRI or arthroscopy. This patient was accurately calculated to have a glenoid bone loss of 13% by using this method. Let us now see how glenoid bone loss is evaluated using MRI. This sagittal MR image acquired and face to glenoid shows normal glenoid surface, which is spear or avocado shaped, with a curved anterior glenoid rim. In this next image, the arrow indicates the anterior straight line, which is a sign of glenoid bone loss. As glenoid bone loss progresses, the anterior straight line also lengthens, and with more severe degrees of glenoid bone loss, the anterior curvature of the glenoid becomes concave. Because only a single shoulder is imaged with MR imaging, side-to-side comparison is not possible, and thus a best fit circle method is most commonly used, as shown in this image. The circle is placed so as to contact the posterior and inferior margins of the glenoid. Measurement of glenoid bone loss is performed by measuring the maximum transverse width of the bony glenoid in comparison to the diameter of the best fit circle. Glenoid bone loss in this case was 23%. Generally, MR measurements tend to be less accurate than those performed using CT scan, at least partly because the inferior two-thirds of the glenoid does not always have a completely circular shape, as shown in this image. A non-circular configuration to the glenoid before any bone loss will not be captured with the best fit circle method. Glenoid bone stock is an important determinant of surgical success and affects the type of surgical repair chosen. There is no universally accepted definition as to what constitutes critical glenoid bone loss, although it can be considered from two standpoints. First, it can be considered to be that critical level where the frequency of dislocation tends to increase. This has been estimated to be about 13%. Second, it can be considered to be at that critical level when capsular repair alone will not suffice to prevent further dislocations, and this has been estimated to be about 25%. The maximum glenoid bone loss incurred is about 33%. This stands to reason since at this measure bone loss has progressed enough to encounter the thick middle one-third of the scapula, beyond which further bone loss is unlikely. Patients with mild to moderate bone loss are treated with arthroscopic soft tissue stabilization alone. Those with severe bone loss require bone augmentation with open surgery. Latarjet procedure, the most commonly performed bone augmentation surgery, involves coracoid osteotomy and its transfer to anteroinferior glenoid rim, as shown here. It is usually recommended for osseous defects of more than 25%. These AP and lateral shoulder views demonstrate bone augmentation with screw fixation of the inferior glenoid rim post-Latarjet surgery. Moving on from glenoid bone loss to humeral bone loss or Hill-Sachs deformity, which of the two Hill-Sachs deformity do you think is likely to engage? Generally, a small Hill-Sachs deformity is located close to the greater tuberosity, with larger lesions seen extending more medially towards the articular surface of the proximal humerus. One should note whether the Hill-Sachs deformity is flattened, like in this case, or is it angulated, as seen in this case, which, though less common, has greater propensity to engage with the anterior glenoid rim. The depth of the Hill-Sachs deformity can be assessed on the eggshell MR images using the best fit circle method, as proximal end of the humerus does approximate to a circle. Remember, Hill-Sachs deformity is measured at or above the level of the coracoid. It is important to consider that Hill-Sachs deformity only comes into play at the end range of stability, such as during abduction and external rotation, where it can engage with the anterior rim of the glenoid. This brings me to discuss the glenoid tract concept. Glenoid tract is the contact area between the glenoid and humeral head during maximum external rotation and 90 degrees of abduction. The glenoid tract was measured initially on cadavers and later on patients using an open MR system and 3D motion analysis software. The mean width of the glenoid tract at 90 degrees of arm abduction was shown to be 83% of the full glenoid width. In other words, the humeral head utilizes only 83% of the glenoid width between neutral and 90 degrees of arm abduction, and this becomes the glenoid tract. Keeping this in mind, let us measure the glenoid tract width in this patient with both glenoid and humeral bone loss using CT scan. 3D reconstructions of the unaffected shoulder is used to measure the maximum glenoid width, which in this case is 28.7 millimeters. 83% of maximum glenoid width should be the actual glenoid tract, which is 23.8 millimeters for this patient. Now on the affected side, the patient has a glenoid bone loss or glenoid tract loss of 5.2 millimeter width. Therefore, the actual glenoid tract of the affected site is the maximum glenoid tract as measured on the normal side minus the loss of glenoid tract on the affected side due to bone loss, which in this case was 18.6 millimeters. Now let us also measure the humeral interval, which is the width of the Hill-Sachs deformity together with the adjacent bone bridge between the Hill-Sachs deformity and the rotator cuff tendons, which in this case was 15 millimeters. The glenoid tract on the affected site is greater than the humeral interval, so in this case the Hill-Sachs lesion was deemed to be on tract or non-engaging. If the glenoid tract is less than the width of the humeral interval, then this is called off tract. This means that in such cases the edge of the Hill-Sachs lesion is likely to extend beyond the margin of the anterior glenoid during maximum abduction. Generally, about 15 to 20% of Hill-Sachs lesions tend to be off-track. Glenoid tract estimation of on-track or off-track lesions has moderate to high accuracy in predicting the likelihood of engagement at surgery, in addition to the likelihood of recurrence following arthroscopic Bankart reconstruction. Remplissage procedure is performed to treat off-track or engaging Hill-Sachs defects. In this surgery, capsule and infraspinatus fill up the large engaging Hill-Sachs defect, usually in combination with anterior Bankart repair. This makes the Hill-Sachs defect extra-articular such that it no longer engages against the glenoid edge during maximum external rotation and abduction. To conclude, based on glenoid tract concept, the surgeons now adopt a strategy to appropriately address both osseous defects in the treatment of recurrent anterior shoulder dislocations. I'll briefly cover multidirectional and posterior instability in the next several slides. Multidirectional instability is defined as instability in two or more directions. Patients present with uncontrolled involuntary inferior subluxation associated with anterior or posterior dislocations. Capsular redundancy is a key predisposing factor in its diagnosis. Common components of capsular redundancy are an elongated inferior capsule and a deficient rotator interval. Rotator interval structures such as coracohumeral and superior glenohumeral ligaments resist inferior glenohumeral translation. Multidirectional instability is treated by open or arthroscopic inferior capsular plication with or without rotator interval repair if the conservative management fails. Capsular redundancy can be suggested on coronal post-arthrogram MR images by presence of an elongated inferior capsule and by measuring the glenocapsular ratio. Park et al. In their published study has suggested that the glenocapsular ratio, which is inferior capsular length divided by length of glenoid, of more than 1.42 suggests multidirectional instability with sensitivity of 92% and specificity of 89%. In this young patient, suspected to have atraumatic multidirectional instability, there was evidence of inferior capsular redundancy with increased glenocapsular ratio of 1.55. Similar inferior capsular redundancy can also be seen with other capsular injuries such as Hagel and Gagel. This MR image of another patient for comparison shows the normal appearance of the inferior capsule. In late presenters, there is usually presence of anterior and posterior labral tears as well, along with inferior capsular redundancy. Rotator interval insufficiency or coracohumeral ligament tear is the other predisposing factor in patients presenting with multidirectional instability, as well as in patients with unidirectional inferior instability. The sagittal and coronal PD post-arthrogram MR images on the top show the normal appearing coracohumeral ligament, whereas the images on the bottom demonstrate tear of the coracohumeral ligament. I'll discuss posterior instability in this last section of my talk. Posterior instability is diagnosed in 2 to 10% of unstable shoulders. It is a commonly missed clinical diagnosis since the findings are subtle and due to reduced index of suspicion. It is also likely to be missed on MRI scans unless specifically looked for. Posterior capsule is one of the most important stabilizers, particularly at the extremes of internal rotation, position in which the most posterior dislocations occur. Subscapularis and to a lesser extent infraspinatus and teres minor provide dynamic restriction of posterior humeral head translation. Principles of management in surgical stabilization are the same as for anterior instability, that is arthroscopic posterior capsular repair and shift, and for bony injuries, McLaughlin procedure. McLaughlin is the other name for reverse Hill-Sachs defect. In this first patient, arrow points to an impaction fracture of the anteromedial humeral head following posterior dislocation. As mentioned in the previous slide, it is also known as McLaughlin lesion or reverse Hill-Sachs defect. Surgically, it is important to identify and correct it to prevent avascular necrosis. In the second patient with posterior dislocation, there is bone marrow edema pattern at the anteromedial humeral head, along with tear of the posterior labrum. Since posterior capsule is the most important restraint against posterior dislocation, and posterior band of IGHL is particularly the weakest portion of the joint capsule, it may be frequently torn with posterior instability. Posterior inferior capsular injuries most commonly involve the humeral attachment and are also known as reverse Hagel or Ragel. Another not so common posterior capsular injury is the Bennett lesion, which is ossification along the posterior inferior glenoid rim, also resulting in remodeling and hypertrophy of the posterior glenoid as demonstrated on these axial PD and sagittal PD images. It is most commonly seen in professional baseball pitchers with history of posterior instability. Posterior labral tear was also noted on the contiguous axial images. A third not so uncommonly seen lesion of posterior labrum is Kim lesion, which is an equivalent of Perthes lesion of anteroinferior labrum. It is especially seen in overhead athletes, most common presentation being shoulder pain following repetitive overhead activity. Scapular periosteum like Perthes lesions remains intact and hence is a type of incomplete labral avulsion although if left untreated can lead to persistent posterior instability. Glenoid dysplasia, also known as glenoid hypoplasia and posterior rim deficiency, is an anatomic variant that predisposes to posterior glenohumeral instability. Harper and his colleagues found moderate to severe glenoid dysplasia in 14.3% MR arthrogram studies, and after including mild cases, the frequency increased to 39.8%. A normal glenoid labrum has a laterally pointing edge and normal posterior labral morphology. Progressive severity of the glenoid hyperplasia results in advanced rounding and sloping of the posterior glenoid. This developmental incongruency of anterior and posterior glenoid results in glenoid retroversion, which predisposes to posterior glenohumeral instability and posterior labral tears. To summarize, I tried to comprehensively cover anterior glenohumeral instability, under which I covered Bankart lesions and other labroligamentous injuries, assessment of glenoid and humeral bone loss, including glenoid tract concept through advanced imaging and some key surgical procedures in their management. I also briefly covered multidirectional instability and its assessment through MRI, and posterior instability, under which I covered some key lesions such as McLaughlin lesion, reverse Bankart's, and other posterior labroligamentous injuries such as Bennett and Kim's lesion, as well as glenoid dysplasia. In the end, I'd like to thank you all for your kind attention.
Thank you, Dr. Tandon, for your insightful lecture. Second speaker is Professor Shalini Agarwal, currently Professor of Radiology of Pandit Bhagatwat Dayal Sharma, Postgraduate Institute of Medical Sciences, Rohtak, India. Professor Shalini will conduct a lecture about imaging of acromioclavicular joint, the cotton joint. Professor Shalini Agarwal, the time is yours.
Good morning to you all. I will be speaking on imaging of the AC joint, which is often forgotten and ignored. It is an important component of the shoulder girdle and it links the axial skeleton with the upper limb. It is a planar diarthrodial articulation between the clavicle and the acromion, and it contains a meniscus-like fibrous disc that is prone to degeneration. The articular surfaces or the facets are covered by a cartilage, which is initially hyaline and converts to fibrocartilage with age. The shapes of the facets are also variable, with a convex clavicular facet articulating with a flattened or concave acromial facet being the most common. So here are images of normal AC joint, the AP view, the axillary view, the Y view, and MRI of a normal AC joint. It is typically slanted 20 to 30 degrees, but varies from being nearly vertical to being nearly horizontal, with the clavicle overriding the acromion. On an average, it measures 9 millimeter in height and 19 millimeter in length. The width of the joint space is 1 to 7 millimeter in males and 1 to 6 millimeter in females and declines with age. So here are MRI images of two patients, and it is slanting in this particular patient and nearly vertical in the second patient. The disc is flexible, meniscus-like, fibrocartilaginous, and continuous with the capsule to cushion the joint and correct for bone incongruence. It does not appear to be necessary. It degenerates by second decade and is typically non-functional in adults. In young adults, the disc is typically meniscoid, continuous with the superior ligament, and attached most firmly at the acromion. Disc desorption, tearing, and superior extrusion along with mineralization, principally due to deposition of CPPD crystals, becomes apparent with aging. So here are images, MRI images of two patients showing a normal disc in a 26-year-old male and a degenerated disc in a 65-year-old female. This joint is supplied by suprascapular nerve and lateral pectoral nerve. It is an important component of the shoulder girdle, which includes clavicle and the scapula and 5 mobile zones. 3 articulations, that is AC joint, sternoclavicular joint, and glenohumeral joint, and 2 gliding zones, which are scapulothoracic and subacromial spaces. Ossification of scapular body and spine commences in utero and ossifies during childhood and adolescence. These centers typically coalesce into four zones: the preacromion, mesoacromion, metaacromion, and basiacromion. Fusion between these zones occurs by 15 to 25 years, usually from lateral to medial side and posterior to anterior aspect. Failed fusion leads to os acromial. So a diagram showing you the four ossification centers. Os acromial is seen in 1 to 15% of population, and it is bilateral in 60% of the population. The non-fusion occurs most commonly at the junction of meso and metaacromion. Axillary views and CT scan are the key to diagnosis of this condition. So here are images of a 42-year-old male, the Y view and the axillary view, which appear almost normal. However, on the MRI image, you can see a partially fused os acromial, and this patient also had features of adhesive capsulitis. Os acromial is usually asymptomatic. Increased mobility at this site is thought to cause increased chances of impingement, and offset or an osteophyte increases these chances. No statistical difference has been found when considering incidence of supraspinatus and infraspinatus tears in these patients. AC joint has both intrinsic as well as extrinsic stabilizers. Acromioclavicular capsule and ligament stabilize the joint in horizontal direction, while coracoclavicular ligament complex provides vertical stability. Dynamic stability is provided by deltoid and trapezius muscles. The intrinsic ligaments are superior, inferior, anterior, and posterior. Normal ligaments are each about 2 to 5 millimeter in thickness. Acromioclavicular ligaments resist 50% anterior and 90% posterior displacement. Superior component is the strongest and is augmented by merging fibers of deltotrapezial fascia. So here is a diagram showing you all the important ligaments of the AC joint: the acromioclavicular ligament, the coracoacromial ligament, the coracoclavicular ligaments, which has two components. MRI images showing you the strong superior acromioclavicular ligament, the coracoclavicular ligament, and the coracoacromial ligament. The coracoclavicular ligament is an important static stabilizer. It is composed of the conoid and the trapezoid component. The conoid component, which is more medial, provides restraint against anterosuperior clavicular displacement and rotation, while trapezoid ligament, which is more lateral, is the primary restraint against anteroposterior translational forces. Coracoacromial ligament is a triangular shaped ligament with a broad attachment on the lateral aspect of coracoid process and inserts onto the tip of acromion. Along with acromion, it forms an arch to protect the humeral head from superior subluxation. So again, the radiographic views, the AP view, it is important to take both the joints so that we can compare differences between the two joints. Then the Y view or the lateral scapular view and the axillary view. Zenka's view is an AP angulated view. The beam is centered over the joint and tilted kephalad 10 to 15 degrees, thereby traversing thinner tissue, optimizing penetration, decreasing radiation dose, and diminishing overlap of the clavicle and scapula. The normal dimensions of AC joint are AC interval of 1 to 3 millimeters, the CC interval of 11 to 13 millimeter, and AC interval of more than 6 to 7 millimeter, or a difference in AC interval of more than 2 to 3 millimeter is significant. And a CC interval difference of more than 5 millimeter is also considered abnormal. The ligament should appear thin and of low signal intensity on all MR sequences. So here is an X-ray showing you increased AC distance and the CC distance on the right side. So please do not forget your bubbles. They will guide you to the kind and the grade of AC joint injuries. In one large study, the use of weights unmasked CC widening and led to higher injury grades in 4% of cases. In addition, paradoxical CC narrowing with weights is reported in 1/3 of healthy volunteers and in 10% of AC injuries. The majority of experienced shoulder surgeons report that they do not require weighted use. Okay, let's look at some of acute AC joint injuries. The incidence is only about 4%, as was seen in a review of all shoulder injuries seen at one urban hospital over a period of 1 year. The humeral fracture, the clavicular fracture, and glenohumeral dislocation occur far more frequently. 70 to 90% of injuries are low grade and are not associated with a visible deformity. The incidence of acute minor injuries is underestimated as they are seen in private care settings and treated conservatively. These injuries occur in young adult males. However, in young male athletes involved in contact sports who were evaluated in a primary care settings, up to 40 to 50% of shoulder injuries involve AC joint. Causes are fall on shoulder. Fall on outstretched hand is an indirect cause. It disrupts the AC ligaments, however, spares the CC ligament, resulting in lower grade injury. Associated injuries to the clavicle, glenohumeral joint, and superior labrum occur in 20% of AC separations. Clinical presentation is superior shoulder pain and swelling. Arm is held in an adducted, supported position to alleviate the symptoms. The clinical diagnosis is made by palpating, applying manual stress, and dynamic maneuvers. An O'Brien active compression test is used to differentiate the AC joint injuries from labral disease. Classification is usually by Rockwood classification system. I have downloaded this from Radiopedia to give you an idea of what this classification is all about. The type 1 injury is a low-grade sprain. The AC distance and the CC distance is almost always maintained. There may or may not be fluid in the joint. The AC capsule is completely torn in type 2 injury, resulting in radiographic widening of more than 7 millimeter. However, the CC distance is maintained. The type 3 injuries involves a tear of the CC ligament with an increase in CC distance. This is again another type 3 injury. I've included this case just to give you an idea of how difficult it is to diagnose this condition on MRI scan. These are two axial images. This is an inferior axial image showing you the acromion, and in the superior image, there is the clavicle giving an indication of type 3 injury. So it is very essential. It is essential to be aware of this injury and look for it when you are evaluating shoulder trauma cases. Type 4 injury involves horizontal plane injury with posterior displacement of the clavicle and palpable AP instability, although examination is challenging in acute injuries. Type 5 disruption of injury involves disruption of the deltotrapezial fascia attached to the lateral end of clavicle, enabling the clavicle to assume a subcutaneous position. Some resources suggest that the presence of deltotrapezial fascia tearing differentiates type 5 from type 3 injuries. This is a type 6 injury with inferior displacement of clavicle. Type 6 injuries are evaluated by means of Weismann's index. This is the distance between perpendicular lines drawn from the most lateral aspect of clavicle and the most medial aspect of acromion on the two sides. Other ways of identifying this injury is by glenochromioclavicular angle and cross-sectional imaging on CT and MRI. CT scan is useful for the assessment of fractures. Accuracy for AC joint injuries is similar to that of radiography. It cannot accurately assess concomitant soft tissue injuries and it uses ionizing radiation. Hence, MRI is preferred for the 5 to 10% of patients with high-grade AC injury requiring advanced imaging for surgical planning. It is also reference standard for delineating regional stabilizers and enables assessment of the bones, rotator cuff, venohumeral articulation, and neurovascular structures. One should also be aware of normal variations. An offset of 2 mm between anterior clavicle and acromion, or a vertical offset of less than 25% of acromial height between the inferior margin of the clavicle and the acromion may be present in 20% of skeletally healthy individuals. Physiological posterior clavicular displacement peaks at 90-degree abduction, which coincides with the arm position in axillary view. Then alternative projections for type 4 injuries include Alexander's view and pseudodynamic axillary view. Here are two images showing you the acromioclavicular offset. Let's look at clavicular fractures, because whether they involve the articular surface or the clavicle is fractured within the body of the clavicle is fractured, it affects the AC joint. There are various classifications of clavicular fractures, and here are two images showing you the fracture of clavicle involving the distal third and the middle third of the clavicle. Distal clavicular osteolysis is another condition that affects the distal clavicle and the AC joint. It generally affects young males. It is bilateral in 20% of cases, and there are two types. It can either be post-traumatic or atraumatic. Atraumatic is stress-induced overuse, as is seen in weightlifters or laborers. Here is an image showing you the distal osteolysis of right clavicle. The left side is normal. Then osteoarthritis and synovial diseases can also affect the AC joint. Here is a patient with frank osteoarthritis at the shoulder joint and the AC joint, and another patient with septic arthritis involving the glenohumeral joint and the AC joint with a large collection and perisynovial edema. So the take-home message is that these injuries are rare injuries and they are difficult to diagnose because of the orientation of the joint and inability to achieve optimal position during imaging. One should be aware of these injuries to achieve optimal post-treatment movement of the shoulder. Thank you.
Thank you, Professor Akarwa, for your wonderful lecture. For participants, as in the plenary session, you can submit your question in the chat box below your screen, and the presenter will answer it directly in the chat box too. The third speaker for this session is Dr. Marcel Prasetyo, currently serves as Assistant Professor for Radiology Service and Medical Staff Development at Department of Radiology of Cipto Mangunkusumo General Hospital, Jakarta, Indonesia. He will conduct lecture in redefining osteoarthritis from radiology perspective. Dr. Marcel Prasetyo, the time is yours.
Ladies and gentlemen, my name is Marcel from Indonesia. It is a pleasure for me to present to you in this annual scientific meeting my topic about redefining osteoarthritis, a radiological perspective. Osteoarthritis is the most common form of arthritis, which causes serious long-term disability. Its prevalence is increased according to age, from 13.9% in younger population to 33.6% in older population. In my hospital, more than 1,200 osteoarthritis was diagnosed radiographically annually, and diagnosing and grading of osteoarthritis become a daily routine, which results in a relatively standard radiology reports. This can be problematic, especially if we consider the clinical symptoms do not correlate well with radiographic diagnosis. There was a study that found 28% patients with radiographic osteoarthritis, apparently only 17% show symptoms clinically. One thing to remember is that osteoarthritis is a clinical diagnosis. The typical presentation is when the patient has aged more than 45 years old with activity-related joint pain, morning stiffness, crepitus, bony enlargement, and no detectable warmth. The purpose of imaging so far is to assess structural changes and monitor progression. If we found a typical presentation, we should consider secondary osteoarthritis due to other causes, or the diagnosis is other than osteoarthritis. Again, there is a lack of concordance between radiographic changes and symptoms, according to a systematic review by Batson and Croft, showed that patients with radiographic knee osteoarthritis with pain ranged from 15% to 81%. Back in the old days, osteoarthritis is considered as a passive degenerative disorder that is so-called wear and tear, and radiography is frequently used for this purpose. Now, osteoarthritis is regarded as an active process driven by mechanical factors, so it's considered as a whole joint disease. Thus, MRI and ultrasonography now have a greater role than before in terms of early detection, improving clinical decision making, understanding disease progression, and evaluation of treatment options. In this presentation, I will focus mainly on the knee joint. Common radiographic projection is AP weight-bearing view with knee extended. However, in this projection, there is a significant challenge that the joint space cannot be visualized clearly. Then, if we want to do some measurements, it can be a problem. Other proposed projection is the Rosenberg posterior-anterior view that provide better visualization of lateral compartment and comparable visualization of medial compartment. This projection can be obtained in a 45-degree knee flexion with both feet 10-degree external rotation and 10-degree caudal angulation of X-ray beam centered at the knee joint. We can see there is a significant difference of joint space between AP view, image on the left, and the PA Rosenberg view, image on the right. Another challenge in radiography is how to ensure a better reproducibility regarding the positioning. For the Rosenberg view, some centers use an additional device, like in this image, that use a acrylic board in order to reduce the technician variability. There are actually several findings that can be addressed in the radiography of a knee joint. We can detect a marginal osteophytes, subchondral sclerosis, subchondral cysts, joint space width, and also osteochondral loose bodies, fracture, and also soft tissue and fat pad edema. This may involve the suprapatellar fat pad, prefemoral fat pad, and Hoffa fat pad. The more information we can provide, the more value we produce in our radiological reports. However, most radiologists, at least in my country, limits their report on only osteophyte and joint space narrowing in terms of Kellgren-Lawrence grading system. The problem with Kellgren-Lawrence system that has been criticized is that it was developed based on the assumption that radiographic changes appear in a consecutive fashion over the course of the disease, while actually it's not. There are, for example, some conditions where joint space narrowing was found without osteophyte formation. or even other bony changes. We can see here the difference of Kellgren-Lawrence grading, that in Kellgren-Lawrence 1, there is indefinite osteophyte formation, while there is also a joint space narrowing all the way until the grade 4. So if we go back to basics, new development in the knowledge of osteoarthritis pathophysiology is the crucial role of synovitis. Products of cartilage breakdown released into synovial fluid are phagocytosed by synovial cells, amplifying synovial inflammation. In turn, activated synovial cells in the inflamed synovium produce catabolic and pro-inflammatory mediators that leads to excess production of the proteolytic enzyme responsible for cartilage breakdown. The inflammatory response is amplified by activated synovial T cells, B cells, and infiltrating macrophages. To counteract this inflammatory response, the synovium and cartilage may produce anti-inflammatory cytokines. In addition to this effect on cartilage inflammation and breakdown, the inflamed synovium contributes to the formation of the osteophytes via BMP. So it is the presence of synovial macrophages that contribute to the formation of osteophyte and subchondral bone formation, not directly related to cartilage loss. We also have to consider structure other than cartilage that result in joint space narrowing. This is a case of progression of joint space narrowing. We can see left and right, same case, same patient, shows a progressive joint space narrowing. There is no sign of osteophyte formation in this case. Apparently, the joint space narrowing is due to extruded meniscus, as confirmed by MRI, and the cartilage, however, remains intact. Other grading systems have been developed by the Osteoarthritis Research Society, and they produce an atlas of grading, a system that separates the evaluation of osteophyte, joint space narrowing, and sclerosis. We can see the comparison between the Kellgren-Lawrence grading that mix the osteophyte and joint space narrowing, while in ORC atlas grading, they scores the osteophyte and joint space narrowing separately. However, if we want to assess osteoarthritic joint as a whole organ disease, we need other advanced modalities such as MRI. There are several parameters can be evaluated in the MR of the osteoarthritic joint. We can evaluate the cartilage and the meniscus. We can also evaluate the inflammatory changes such as synovitis and joint effusion. Subchondral marrow edema can also be visualized, cartilage defect, and also osteophyte formation. There are several scoring systems have been developed to standardize MR evaluation of the osteoarthritis. For example, there are worms, blocks, molds, but most of them are still for research purpose. Apparently, synovitis is gaining more attention in the evaluation of osteoarthritis. In the early phase of osteoarthritis, with normal radiographic finding, we can find synovitis and joint effusion. These findings also correlate well with clinical pain and disease severity that makes it a promising marker to evaluate structural changes and clinical outcome. There is a study back in 2010 that tried to evaluate synovitis in osteoarthritis, and they found that number of region of synovitis apparently consistent with the increase of Kellgren-Lawrence grading. And based on the location also, synovitis near the posterior cruciate ligament appears to be frequently found in knee osteoarthritis compared to other sites. Of course, ideally, we're going to need the use of contrast media to visualize synovium. This is simply because we cannot differentiate joint effusion and synovial edema just using a standard T2-weighted fat-saturated non-contrast MR. We can see this is the same patient, same area, and the left one is without contrast and the right one is with contrast, and we can see the difference that we're gonna need contrast media to visualize synovium clearly. But of course, the routine use of contrast media for osteoarthritis can be very costly. Some study has tried to utilize fat edema as the surrogate for synovitis in a non-contrast MRI. However, one must always consider that there is other numerous causes that can also cause fat edema. This may include, for example, infection, trauma, and impingement. Another feature of osteoarthritis that can be visualized easily using MR is cartilage. Usually we do proton density fat saturated sequence or T2 weighted fat saturated sequence to visualize cartilage. We can detect morphologic changes of the cartilage such as fibrillation, fissure, defect, and other osteochondral lesions can also be visualized directly. Intact cartilage nowadays can also be evaluated using advanced biocomposition technique of MR. You can see there are several of the technique. Most are still in research, but T2 mapping is the most frequently used so far. T2 mapping is based on the collagen network and water content. So in an intact morphology cartilage, if there is a breakdown in collagen network, water content will increase and T2 value of that particular region of cartilage will also increase. Although morphologically it still looks normal. This is an example of T2 map for evaluation of the biocomposition of the cartilage. This is the MR of the lateral compartment of the knee. The left one is T2 map and the right one is proton density fat saturated sequence. We can see in PD the intact cartilage, and in the T2 map at the left side we can see there is a brighter color, that means higher T2 value that is expressed in milliseconds. This means that we can do an early detection of the cartilage damage even before morphological damage occurs. Ultrasound can also be utilized in osteoarthritis. Although ultrasound cannot visualize the whole cartilage, it can be useful in assessing synovitis, meniscal extrusion, and osteophyte formation. Synovitis can be easily visualized, and its activity can be shown using Doppler examination. Meniscal extrusion, on the other hand, can be detected that can explain joint space narrowing due to displacement of the meniscus as measured in the image. Osteophyte formation is also found to be more sensitive to be detected using ultrasound in comparison with radiography. So in summary, we are now considering osteoarthritis as a whole joint disease. Radiography will serve as an initial assessment to evaluate structural changes, and In a typical clinical presentation, we also must consider the diagnosis. One thing to remember in evaluating radiographic appearance of osteoarthritis that it is not just about osteophyte and joint space narrowing. However, there is increase of role of MR and ultrasound in terms of early detection, monitoring progression. We can evaluate directly the synovium, meniscus effusion, and cartilage, and we can also use contrast media and special blood sequence that will be potentially increased in the future. And we as radiologists need to be able to answer this challenge to help our patients. This is my list of reference that I use if you are interested for further reading. And I thank you very much for your kind attention.
Thank you, Dr. Marcel, for the insightful lecture of redefining osteoarthritis. Last speaker for this session is Dr. Anita Mandava. She is a senior consultant radiologist at Basara Vatakam Indo-American Center Hospital and Institute, Hyderabad, India. She will talk about radiography disease of the hip. Dr. Mandava, the time is yours.
Hello everyone, greetings from India. I'm Dr. Anita Mandava, and today I'll be speaking about radiographic evaluation of degenerative diseases of the hip. So the objectives and the outline of my topic would be today I'll be doing an introductory slide, then we'll see various types of osteoarthritis or degenerative diseases, radiopathological correlation, clinical features, and the imaging features. So the approach to this is a very old slide from radiology, updated from radiology 2008, but still till date it's a very relevant slide and really like it. The approach to any disease of joint starts with the evaluation of joint space narrowing, and we have to see whether the joint space narrowing is symmetric, whether there are any erosions present, and whether it is associated with some soft tissue swelling. If there is a symmetric joint space narrowing associated with erosions and soft tissue swelling, we will consider as inflammatory joint disease. If a single joint is involved, most likely it is an infection. If there are more than one joint involvement without any bony proliferation, and if the proximal joints are involved, then we have to consider rheumatoid arthritis in our differentials. Again, multiple joint involvement, especially distal joint involvement, along with bony proliferation, seronegative spondyloarthropathy comes into the closest differential. And if the joint space narrowing is asymmetric, and if it is associated with osteophytes and sclerosis, then it becomes degenerative joint disease. In this, we have typical osteoarthritis or atypical osteoarthritis, which is secondary to some other disease like crystal depositions or neuropathic joints or hemophilia. We'll see them in detail. So, degenerative joint disease, otherwise known as osteoarthritis or osteoarthrosis, is the most common joint disease. It's a non-inflammatory joint disease, chronic disease without any systemic involvement, and there is no joint ankylosis in the course of disease. So, etiologically, it is either primary osteoarthritis, where there is no etiology is known, or secondary osteoarthritis, which is secondary to some other known disease. So, coming to the pathogenesis of osteoarthritis, it begins with an interplay of systemic biochemical and local biomechanical factors. Some people are more susceptible by age or female gender or ethnically, and associated with some nutritional factors or any local biomechanical factors such as joint injury or deformity, obesity, they lead to osteoarthritis. So what are the risk factors for osteoarthritis? Age is the first risk factor. As the age increases, the incidence of osteoarthritis increases. And gender, in men more than 50 years, you see more osteoarthritis, and in women more than 50 years, they are at higher risk. And as I previously said, local joint biomechanical abnormalities lead to increased osteoarthritis. So the major pathology in osteoarthritis involves the articular cartilage. If you see on my right side, normal articular cartilage, whereas in osteoarthritic cartilage, you can see the tears and wear and tear in osteoarthritic cartilage. So what exactly happens in cartilage is there occurs cartilage fibrillation and then leading to eburnation and osteophyte formation of the underlying bone. So we see the radiopathological correlation in osteoarthritis. So if there is cartilage, articular cartilage fibrillation, ulceration, erosion, it can manifest as localized joint space narrowing in radiological findings. This would be the first radiological sign we see on a degenerative joint. Then leading this articular erosion and ulceration, it leads to increased osteoblastic activity of the underlying bone, leading to new bone formation, which manifests as subchondral bony sclerosis on radiographs. And cartilage and bone proliferation due to revascularization leads to osteophyte formation, especially marginal osteophyte formation. Subchondral microfractures occur whereby synovial fluid goes inside the bone, leading to bone cyst formation, bone weakening leading to bone collapse. And ligamentous laxity, adjacent ligamentous laxity leads to gross deformity or subluxation of the bone, underlying joints and bones. Fragmentation of bones and cartilage within the joint can manifest as loose bodies within the joint, which we can see as loose bodies in the joint on radiographs. And calcium pyrophosphate CPPD crystal deposition disease can manifest as fibrocartilage or hyaline cartilage calcification on radiographs. This is about the radiopathological correlation. So how does it present? Clinically, osteoarthritis of hip can present with joint stiffness and swelling, pain in the hip, especially in the gluteal and groin region. Sometimes it may even radiate to the knee. And walking and function is limited. This is the most important cause of falls and disability in old age and the major indication for joint replacement surgery. On physical examination, patient may have antalgic limping or patient may have limited range of movements, especially internal rotation will be gone first and tendon test may be positive and there will be a leg length discrepancy between both the lower limbs. As far as laboratory findings are concerned, there are no pathognomonic lab findings for osteoarthritis. So that is only to lab analysis is only to rule out some other pathology like rheumatoid arthritis. It's for mainly for differential diagnosis. Then how is the diagnosis done? Diagnosis is by clinical findings where you may find major joint pain and radiological findings, that is presence of osteophytes in the joint. What are the aims of imaging in degenerative disease? The aims of imaging is first to confirm the diagnosis. Diagnosis is confirmed by looking for the presence of characteristic features of osteoarthritis in the absence of evidence of other inflammatory arthritis. So the characteristic feature is marginal osteophytes, presence of marginal osteophytes. Then the other aim of imaging is the assessment of severity. This is done by looking at the joint space narrowing, presence of bone sclerosis, and presence of subchondral cysts. And to classify the osteoarthritis or degenerative disease into primary or secondary types, and then to look for chondrocalcinosis, to identify chondrocalcinosis on imaging. And final aim of imaging is to identify the complications of degenerative disease, that is like subchondral bone necrosis or any other associated pathologies. These are the goals or aims of imaging. So the first imaging modality and the primary imaging modality in degenerative disease is still radiographs. The characteristic radiographic findings, I have given a diagrammatic representation here. The first characteristic feature is the presence of marginal osteophytes at the acetabulum or at the femur, then subchondral sclerosis, joint space narrowing, and subchondral bone cyst formation. So the plain radiographs of hip, what we require are AP view and weight bearing radiographs in frog leg views will give us a quite good picture. So here are the radiographs where you can see marginal osteophytes at the margin of acetabulum and then buttressing at the femur, neck of the femur, you can see the buttressing. These are the earliest changes of degenerative disease. The second most important feature is joint space narrowing. Hip joint space narrowing is asymmetric, especially with the superior migration of femoral head in degenerative disease. Femoral head migration can be superior or medial or axial. It is always superior, especially superior-medial compared to superior-lateral and superior-medial migration in degenerative disease. So this is the earliest sign where the femoral head tend to subluxate laterally, and always this joint space narrowing we should compare with the other side, opposite side. This is where we see initially the superior lateral joint space is reduced, whereas in rheumatoid arthritis it will be the superior medial. So later the entire joint space may be narrow. So because of this joint space narrowing and migration, you can see migration of femoral head. Again, another pictorial depiction. You can see joint space narrowing, especially superior lateral joint space. Then formation of subchondral cysts. These large subchondral cysts are known as Egger cyst. Formation of this subchondral cyst, subchondral sclerosis. This is a typical radiographic appearance of severe degenerative disease of hip joint. So these are the radial graphs. Here you can see the superior lateral migration. Here we can even see the medial migration of the femoral head. Coming to the type of arthritis, degenerative arthritis, we have either primary osteoarthritis, where we can see the characteristic findings of joint space narrowing, subchondral sclerosis, marginal osteophytes, cyst and pseudocyst, or secondary osteoarthritis, which is secondary to several other conditions. These are the characteristic features of primary osteoarthritis, osteophytes, subchondral sclerosis, and then you have subperiosteal or cyst, subchondral cyst formation within the bones. These are the characteristic findings. Coming to the secondary osteoarthritis, each of the condition may have specific radiographic finding associated with it. Post-traumatic joint disease, patient has a history of trauma. Generally, they'll be of younger age. Single joint, unilateral joint involvement of unusual severity may be noticed. In patients with slipped capital femoral epiphysis, they can have something called as the Herndon humps, which is nothing but a bare area over the anterior and superior area of femoral neck that gives an appearance of a hump. And there will be again associated joint space loss and osteophytosis. In CDH, we can see it can be unilateral or bilateral. We can see the signs of hypoplasia of the acetabulum. And in Perthes disease, again, it could be unilateral or bilateral, osteonecrosis of femoral head, leading to coxa magna, that is the short, broad femoral neck, along with lateral subluxation of the femur, can be seen in Perthes disease. Inflammatory arthritis, mostly, as I said, medial and axial migration of femoral heads is seen. In degenerative disease, we don't find any osteoporosis, whereas inflammatory arthritis is associated with the periarticular osteoporosis. In these patients, patient can develop secondary osteoarthritis, degenerative changes in the joint. Again, in osteonecrosis, because of avascular necrosis, we can find increased bone density and crescent signs, fragmentation of the bone, underlying bones. All the features associated with osteonecrosis may be found along with degenerative changes. In Paget's disease, generally coarse articulation and cortical thickening of the bone is seen along with the degenerative changes. So secondary osteoarthritis due to calcium pyrophosphate dihydrate crystal CPPD deposition, we can find chondrocalcinosis of the pubic symphysis and the hip labrum. Another condition is hemophilia, which is seen in young patients that is associated with joint space loss, subchondrosis, and joint swelling due to effusion from repeated hemorrhages into the joint cavity. So in these patients, we have presenting with rapidly progressing degenerative hip joint. So post-traumatic osteoarthritis, here is a case where there is deformity of acetabulum and femoral head with complete protrusion acetabuli. So the same patient with coronal reformated image, there is complete loss of joint space with protrusion of the acetabulum, protrusion of the femoral head into the acetabulum. Again, periarticular sclerosis we can find. Same axial image, this is ununited anterior column fracture along with severe subchondral cyst formation with OA changes in the right femur. So this is another case of rheumatoid arthritis with superimposed osteoarthritis. You can see medial migration of the femoral head, which is more common in rheumatoid arthritis than in degenerative osteoarthritis. Marginal erosions again are common with rheumatoid arthritis. And the secondary osteoarthritic changes are the formation of marginal osteophytes and subchondral cysts. So again, another case of rheumatoid arthritis. One specific feature of rheumatoid arthritis, by definition, it is bilateral symmetrical disease. So you are having changes in both hip joints, bilateral erosions with loss of joint space, with secondary osteoarthritis changes. So coming to the hemophiliac joint, you find specific bone erosion, the symmetric joint space loss, and subchondral cyst. And this periosteal pseudotumors, the calcification in the soft tissues is characteristic of hemophiliac joint. MRI confirms the diagnosis of hemophilia. Neuropathic joints, which is associated with complete disorganization of the joint, fragmentation, subluxation. And characteristically, osteoporosis is absent in neuropathic joint. This neuropathic joint, they represent severe manifestation of degenerative joint disease. As I said, postal cox arthropathy described in elderly females with rapidly progressing osteochondrolysis. So this there is severe destructive process, complete flattening of the femoral head with lateral subluxation we can see in this postal cox arthropathy. So these are the images, and again MRI, especially gradient T2 star weighted MRI. We can see the joint effusion with hypertrophied synovium, subchondral cyst, and within the both acetabulum as well as the femoral head. The next modality of investigation is the CT. CT is not exactly diagnostic; it is only confirming the diagnosis. Here we can see the typical features of degenerative joint disease is narrowing, focal narrowing of the joint space, marginal osteophytes we can see, subchondral sclerosis and subchondral cysts both in the acetabulum and the femoral head. Characteristic features of osteoarthritis. The next modality of imaging is MRI. MRI per se is most valuable for direct visualization of the adjacent soft tissue, including labral and cartilaginous evaluation. Early cartilage loss, it is very sensitive, especially gradient echocoronal and sagittal sequences can best demonstrate it. And morphological and quantitative imaging approaches like delayed gadolinium enhanced image, where what they do is they do 15 minutes of exercise, then after 30 minutes of delay, 0.4 ml of gadolinium per kg body weight they inject, and they try to evaluate the joint changes in this delayed gadolinium enhanced MRI. So what typically they assess are they will again look for the same thickness of the cartilage loss. They look at the subchondral cyst, and we look at synovial presence of effusion or synovial thickening, and for any other loose bodies within the joint space. Same here, we find a coronal weighted image with focal loss of cartilage, synovial thickening, and osteophyte formation and buttressing also you can see in this image, coronal T1 weighted coronal image. So there is something called as the scoring system where it was given in this article, which was published in Osteoarthritis and Cartilage. And in this scoring system, the features which were evaluated were like soft tissues, the assessment of soft tissues, assessment of articular cartilage, assessment of bone was done, and each was given points. So in soft tissues, first labral damage, whether the labrum is normal, whether there is any intralabral tear, or whether the tear is partial thickness or full thickness. Then associated paralabral cysts were looked upon. For the articular cartilage was assessed for damage, whether there is any focal defect or a generalized defect. Anything more than 10 mm defect in the cartilage, you consider it as a generalized defect. And in the assessment of bones, the acetabular bone cyst, either central bone cyst or rim bone cyst, femoral bone cyst, and osteophytes. Both acetabular and femoral osteophytes were looked for, and specific points were given. So the maximum points that can obtain for a severe osteoarthritis, the MR score was 70, which indicates worst outcome, and the minimum possible was 0, which indicates good outcome. So we can see the morphological pattern, the images of morphological pattern. This is a normal cartilage or labrum, and here we can see focal cartilaginous defect. Same cartilage defect more than 10 mm we consider as generalized cartilage defect. Then labrum partial tear or labrum full thickness tear, and these are paralabral cysts, acetabular central bone cyst, or acetabular marginal rim bone cyst. Then comes the femoral bone cyst within the femur, acetabular rim osteophytes, and femoral osteophytes. These are the parameters which were considered and points were given for evaluating. So by this, MRI is helpful for the quantitative assessment of osteoarthritis and to give it into severity as mild, moderate, or severe. This is about the radiological evaluation. Coming one slide about the management of osteoarthritis, majority early stages, it's either conservative management, especially to decrease the weight-bearing joint, weight control joint loading by using support, splinting or walking sticks or walkers, and then exercises, muscle strengthening exercises, physiotherapy, and painkillers. Surgical management includes joint lavage with arthroscopy and cartilage grafting And surgeries, major surgeries are arthrodesis and joint replacement surgeries. Arthrodesis is no longer done. The hip joint replacement is the major surgery done for severe osteoarthritis. In summary, plain radiography is still the standard method to assess the extent of degenerative disease of hip, and the four cardinal radiographic features are joint space narrowing, subchondrosclerosis, osteophyte formation, cyst or pseudocyst formation. CT scan is further characterizing the features, and MR for early detection and morphological and quantitative assessment. Thank you very much for the organizers for giving me this opportunity. Thank you.
Thank you, Dr. Mandava, for wonderful presentation. And now this is the last speaker of this session. We are going to have a lunch break from 12:50 until 13:20. And afterward, all participants can come back and enter the Hall A and Hall B again for last session for today. Hall A will cover the topic of spine imaging, and Hall B will cover lower extremity imaging, each with 4 distinguished speakers. See you after the lunch break. Thank you. General topic for this session is all about lower extremity imaging. Please welcome the first speaker, Dr. Perami17Sept22HallB, who served as Chief Radiologist at Global Hospital Vijayawada, India. He will deliver his lecture about imaging of Achilles tendon. Dr. Perami17Sept22HallB, the time is yours.
Good morning, good evening, and good afternoon for the viewers from the various parts of the world. At the outset, let me thank the organizers for giving me this opportunity and for the wonderful arrangement of the conference. Today I'm going to talk about imaging of tendoachilles. Tendoachilles is the tendon formed by both the heads of the medial and lateral heads of the gastrocnemius and soleus muscle, and forming a very long tendon and inserted into the posterior surface of the calcaneum. On radiograph, we can see this is the soft tissue density is the muscle, and this is the tendon which is inserting into the calcaneum and the posterior surface. On ultrasound, it has a smooth linear fibrillar structure, and anteriorly there is a Krieger's fat pad. On MRI, it has a very straight anterior border and a linear, nicely hypointense tendon, all the sequences inserting into the posterior surface of the calcaneum. It is the largest and strongest tendon in the body and most frequently injured tendon of the body, and it is responsible for plantar flexion of the foot. You can see these images in MR. Tendoachilles in sagittal images have a very smooth anterior border and hypointense in all the sequences. On axial images, it has a little concave inner surface, that is the anterior surface, and has a wide footprint attachment to the calcaneus and posterior surface. You can see in axial images the nicely visualize the fibrillar architecture of the tendon. This is the Krieger's fat pad. You can see this in this axial image of MRI. There is a wide footprint of attachment of the tendoachilles onto the posterior surface of the calcaneus. A word about Krieger's fat pad. The fat pad, which is almost a near triangle seen anterior to the tendoachilles, is known as Krieger's fat pad. This fat pad gives a landmark and clue for us for the inflammations, edema, irritations around the posterior aspect of the ankle and anterior to the tendoachilles. You can see it's uniformly hyperintense on T1 and T2. Weighted images are nicely suppressed in fat suppressed sequence. Sometimes we have fibrous septa within. On ultrasound, the tendoachilles is evaluated in both longitudinal and horizontal positions. Usually we use 5 to 12 MHz probes in prone position and foot hanging over at the edge of the table, where we can dorsiflex and plantar flex the ankle easily, and evaluate both in longitudinal and transverse planes. In longitudinal, it has a smooth fibrillar architecture, a linear tendon with a smooth anterior and posterior margins. On transverse, we can see the thickness of the tendon and its uniformity, and also anterior to the tendon is the Krieger's fat pad. We can also use color Doppler for looking at any inflammatory conditions adjacent, and use the extended field of view and ultrasound to see the evaluation proximally where we have the musculotendinous tears, and properly evaluate the musculotendinous junction and muscle proper. This is an ultrasound cine image in transverse axis. You can see this tendon here and the muscle of the gastrocnemius and soleus muscles here. The tendon is becoming thicker and thicker as it is coming from superior to the inferior, and also see there is spiraling of the fibers from one end to the other end. We can see this convexity is migrating and it's swelling from one end to another end. This gives the spiraling architecture of the tendon, which is more important for its strong nature and also stability instead of taking a lot of weight bearing of the human body. A word about a normal variant. So you can see here the soleus muscle is far low and inferiorly attached to the gastrocnemius and tendon. And on axial images, in place of Krieger's fat pad, we see a signal intensity here. This is the low insertion of the soleus, whereas a word about the accessory soleus, where we have a accessory tendon of the soleus inserting on the paramedian aspect of the calcaneum. So once we see a tendon which is inserting into the paramedian aspect of the calcaneum, it is a accessory soleus. If you don't see any tendon attaching here and only the low position of the soleus, it's a low position of the soleus or low insertion of the soleus. A normal variant, just to keep in mind. And any inflammations adjacent to the Krieger's fat pad, whether osseous or peritendinous or bursal inflammation, affects the Krieger's fat pad. Krieger's fat pad altered signal intensity, hyperintense or fluid sensitive, signal intensity within the Krieger's pad always should give us clue and suspicion that to check for the adjacent osseous or tendinous pathologies. This is one of these osteomyelitis, and you can see the serious Krieger's pad inflammation here. And in infiltration conditions around the peritendinous areas also can involve the Krieger's pad with the loss of Krieger's pad. You can see this infiltrative pathologies around the tender Achilles infiltrating the Krieger's pad here. Coming to the two important bursae here, the retrocalcaneal bursa, which is posterior to the superior surface of the calcaneum, posterior superior surface of the calcaneum, anterior to the tender Achilles. At this location, it's called retrocalcaneal bursa, and it's the most frequent bursa to be inflamed or to be irritated and having the fluid or inflammation around the tender Achilles. Another small bursa, which is a subcutaneous bursa, which is known as retroachilles bursa, which is present posterior to the tender Achilles, insertion of the calcaneus. The measurements of retrocalcaneal bursa are 6 × 3 × 2 mm superior, inferior, transverse, and AP dimensions. You can see here there is a fluid anterior to the tender Achilles. This is the retrocalcaneal bursa. The little thin fluid is can be present normally also, but more fluid, more than the measurements dimensions which measured, always should give a clue that there may be some pathology going on. And this free fluid posterior to the tender Achilles is in the retroachilles bursa. Coming to the conditions, the most common conditions is the degenerative changes in the tender Achilles, that is tendinosis. We have two types of conditions, that is insertional and non-insertional. Insertional is most common in old people who are sedentary or due to some secondary causes like reactive arthritis, rheumatoid arthritis, ankylosing spondylitis, gout, HIV, etc. And usually because this is degenerative in old age associated with the calcaneal spurs, retrocalcaneal spurs, and maybe associated with retrocalcaneal or retroachilles bursitis. Non-insertional is common around 3 to 6 centimeters from the distal calcaneal insertion site. Usually common in middle-aged people and who are runners, athletes, and dancers, where there is more stress on that particular distal one-third of the tendon, and it's more prone for tears and injuries. We have four types of degeneration: hypoxic, mucoid, lipoid, and calcific. Hypoxic degeneration is the most common degeneration which happens in the tender Achilles, where you can see normally we should see a straight anterior button the tender Achilles on sagittal images, but here we can see there is a convexity here and the tendon is markedly hypointense. The only clue on MR to say that this tendon is having hypoxic degeneration is anterior convexity. Bulkier the tendon, anterior convexity, and if you carefully see a little bit more hypointense, this is hypoxic degeneration. This degeneration is going to have a macroscopic tears in future. Then coming to the mucoid degeneration, this is the most common degeneration occurs in tender Achilles, and most of the times it is asymptomatic. You can see linear intratendinous signals. It also having the convex anterior bulge. It's already having the hypoxic degeneration, and mucoid degeneration in the next stage. You have a linear signals within the tendon, but not this hyperintensity, not as bright as the fluid within the joint. So this is a degeneration, not a tear. And these are also going to have a common macroscopic tears along with hypoxic degeneration. The other degeneration is the lipoid degeneration, where the tender Achilles is bulky and infiltrated with fat, and most commonly associated with type 2 hypercholesterolemias or xanthomas. The final degeneration is the calcific degeneration. We can see the tender Achilles is bulky and also having convex margins and associated with degenerative changes, spurs, and dense calcifications in the tender Achilles in the distal one-third. This is the calcific degeneration. How it looks on MR, this is a calcification hypointense on most of the sequences, and we can see in this particular tendon, calcific degeneration is the last degeneration, and usually once you see a calcific degeneration, the tendon is also having the hypoxic degeneration, where the tendon is bulky and markedly hypointense, also mucoid degeneration, where you have intratendinous linear signal intensities. A word about a particular condition, where we can see in this particular condition where there is a mucoid degeneration within the tendon along with hypoxic degeneration. But what is the cause for this? You can see there is a tubercle in the posterior superior aspect of the calcaneus, which is called Haglund's tubercle. It is present whenever the foot is plantar flexing and dorsal flexing, and this causes irritation or mechanical stress on the tendon and makes it prone for the degeneration, hypoxic degeneration, mucoid degeneration, followed by sometimes by tear. You can see this osseous edema adjacent to the Haglund's tubercle in the posterior aspect of the calcaneum, and this condition is known as Haglund syndrome. You can see here the retrocalcaneal bursa is full, and the hypoxic degeneration of the tendon and the posterior prominence of the bone here in the calcaneus, that is the Haglund's tubercle, and this condition is known as Haglund syndrome. How to diagnose this? If you draw a line on the superior aspect and the inferior aspect which are parallel to each, perfectly parallel to each other, and any protuberance more than 4 to 6 millimeters is known as a Haglund's tubercle. These lines are known as pitch lines. There is another special entity which is a dense calcification noted, a calcific density noted in the tender Achilles, which may be a small or a very large like this in this particular case, which is having the trabecular pattern. Once we see a trabecular pattern, it is ossification. So it is not calcification. It is ossification of the tender Achilles. This is also a not very rare entity to be kept in mind. A word about elastography. You can see a normal tender Achilles and normal blue color elastography. As the tender Achilles is degenerating, you can see tendon is enlarged, heterogeneously hypoechoic, anterior convexity, and the color is also translating from the blue to green and green to red. So saying that this tendon is degenerated. Coming to the few examples which can involve the tender Achilles as infiltrative pathologies here, we can see a density here in the posterior aspect of the ankle which is infiltrating the tender Achilles. And on radiograph the bone appears normal, even on MR the bone appears normal. And we can see a hypointense infiltrative pathology encasing the tender Achilles and also involving the Krager's fat pad, which shows blooming on our GR images, saying that this is a pigmented villonodular synovitis. To remind here, the tender Achilles is not having a synovial sheath. Probably this is from the posterior capsule of the synovium. And this is having the paratenon, which is not a synovial sheath, which is the condensation of adjacent fat in areolar tissue, which is a paratenon. And tender Achilles may be having a paratenonitis, but not a synovial sheath. Another infiltrative pathology here, tender Achilles is bulky and having a lot of fatty infiltration and lipoid degeneration here in this 35 years female, which is present on both sides of the ankle, bilateral, relatively symmetrical, and we have a doubt of a particular infiltrative pathology condition. This is an ultrasound, tender Achilles bulky with fatty degeneration, and we did ultrasound of this particular patient. This patient is having some cholesterosis on gallbladder, and incidentally we try to evaluate this condition with the suspicion we can see this bilateral cerebellar lesions. When you have a clinical examination of this patient, you can see that on both sides there is relatively symmetrical involvement of the tender Achilles and also cutaneous xanthomas in this particular condition and as cerebrotendinous xanthomatosis. Whenever you have the bulky bilateral symmetrical xanthomatous infiltration of the tender Achilles, always try to evaluate for cerebrotendinous xanthomatosis. Coming to the tears. This is very important to classify the tear, whether it is an insertional tear or non-insertional tear. This is common in old age and for a secondary causes, whether it's traumatic inflammatory condition. This is more common in middle age and very active people like dancers and runners. Once you have a complete tear, you have to mention about degree of retraction and whether the edges are smooth or frayed and irregular, any hemorrhage or fluid between the torn ends of the tendon, and what is the extent of the tear. It is in a transverse axis where it is confined to the medial end or medial one third or middle one third or lateral one third, or involving the medial 2/3 or lateral 2/3. We have to describe it like this. And in AP axis, if it is involving less than 50% of the tendon thickness, it is low grade tear, and if it extends more than 50%, we name it as a high grade tear. You can see in the few examples here in 23 years male where you have the tendon bulky anterior as a classical. Once the tendon is bulky and anterior convexity is hypoxic degeneration, and also this patient is having a mucoid degeneration. Along with the mucoid degeneration, we have very bright signal within the tendon almost equivalent to the joint fluid, which is a interstitial tear of the tendon. If you try to classify this is confined to the central one third of the tendon and less than 50% of the tendon. So a low grade central interstitial tear confined to the central one third of the tendon. This is how we have to describe this particular tear. Another 59 years patient, you can see this tendon is bulky, having a mucoid and hypoxic degenerations, and also a very bright signal. Especially you can see this tear extending the transverse axis. This is less than 50%, but extending into the two 1/3, that is the medial and central 1/3, and you can say this is not a complete tear, a partial tear of the tendon, a horizontal tear confined to the less than 50% of the tendon and involving the medial 2/3 compartment. So this is how we have to describe about tendon tears. Whereas in this particular example, if you can see this, there is definitely hypoxic degeneration, anterior convexity of the tendon, and you can see a signal which is extending like this in a semilunar shape. In axial image, you can see this is almost involving the near total thickness, but confined to the lateral 1/3 and also extending into the central 1/3, but not including total. These are more than high grade tear on axial images. More than 50% of the tendon is involved, and also confined to the two 1/3, that is the medial and lateral 1/3. Whereas in this particular example, where you can see this tendon is torn here and the edges are very smooth, tendon is torn here, edges are very smooth, and this is the gap between the tendons, and these are the retracted segments, and this is a non-insertional area. Insertional tears are common here, and non-insertional tear in this particular athlete. So we have to say that non-insertional complete full thickness tear of the tender Achilles with a gaping of 1 to 2 centimeters and with a smooth margins, and these can be sutured. These are the torn ends of the tendon with a lot of fluid and hemorrhage. You have to measure these two ends, and you have to mention in our report. That is important for the management. Another examples of the TS male, where you can see this on these midline sagittal images, we see we can feel that there is a complete tear of the tender Achilles, an insertional tear, and a lot of gap. But actually, when you see these axial images, there are few fibers which are intact on the lateral 1/3. So this is a high grade tear. More than 50% of the thickness of the tendon is involved, and medial 1/3 and middle 1/3 of the tendon is involved. And whatever the high grade torn fibers are retracted to this much centimeters from measuring from here to here, and few intact fibers on the lateral 1/3 are intact. This is another example of the TATS female, where you have a tear in the middle fibers, and the medial and lateral 1/3 fibers are intact. These fibers are torn and also retracted, and we have to measure this tear measurement from the insertional site of the calcaneus. So why this measurement and all these things important? They are very important for the management. Type 1 tears are partial tears, where there is a tear of less than 50% thickness of the tendon. And type 2, 3 and 4 are complete tears, where the gap is less than 3 centimeters. Classified into type 3 if more than between 3 and 6 centimeters, and gap classified type 4 if gap is more than 6 centimeters. Type 3 and 4 require tendon or a synthetic graft, and this can be managed with a suturing. An interesting example to a couple of slides, where you can see this appears like a calcification, but is not a calcification. This is inline of the tender Achilles, but you can see the donor area in the superior surface on the posterior aspect of the calcaneum. So this is an avulsion fracture of the tender Achilles. There are three types of injuries. This is called as a beak fracture. And also there is a sleeve avulsion in the central portion of the tender Achilles, that's called type 1, and type 3, where you have the posterior tuberosity, which is very centrally located, and the peripheral fibers are intact, and the anterior fibers are mostly torn in this. So this type of fracture is known as type 3 fracture, and depending upon the fracture types, we have the various types of treatment. Coming to atypical injuries. Atypical injuries are proximal injuries. Clinically, the patient have tender Achilles insufficiency or impairment function of the tender Achilles. But tender Achilles, when you try to examine from the insertional site proximally, most of the tender Achilles appears normal. But these patients will have the proximal muscular tendinous injuries of the tender Achilles, where you can identify with the fluid along the muscular tendinous junction. On your coronal images, you can see this like a V-shaped appearance of the posterior surface of the tender Achilles muscular tendinous junction, and this is from the literature. And this is common in males, and the middle of the gastrocnemius muscle and muscular tendons are more commonly involved, and dominant leg is more commonly involved. These injuries are more common in gastrocnemius muscle because gastrocnemius muscle crosses the two joints. Whenever a muscle crosses the two joints, it's more for injuries. And not only that, it has an eccentric contraction and also have a fast twitch fibers. All these characteristics make the gastrocnemius more vulnerable. That to the medial head is more vulnerable in the dominant leg. Sometimes you can have a feathery type of appearance, especially you can see this feathery type of appearance along the muscular tendinous junction of the muscle here, and this is a low-grade muscular tendinous sprains or injuries. What about plantaris? Plantar is also an important tendon coursing along the medial side of the tender Achilles inserting to the calcaneus. Whenever you see a tendinosis or peritendinitis in the middle part of the tender Achilles, usually they are associated with the plantaris tendon pathology. That you need to be careful in our reporting. We always try to see along with the tender Achilles the plantaris tendon, whether it's intact or not, whether any abnormality is there in the plantaris tendon or not. There is one normal variant which is known as triceps surya complex, where the plantaris tendon has the multiple slips. Some of the slips inserts to the calcaneum, some of the slips inserts into the tendinochleus. So the tendinochleus pathologies or tears maybe also the plantaris tendon tears also, and the plantaris tendon pathologies can translate into the tendinochleus pathologies. So a word of caution about the plantaris tendon, its course. We need to evaluate this plantaris tendon along with the tendinochleus when you are looking for the pathologies of the tendinochleus. Finally, to take home, just keep an idea of the various types of degeneration: hypoxic, mucoid, lipoid, and calcific degenerations. Once you have the hypoxic and mucoid degeneration, these tendons can go for macroscopic tears, and be cautious that this tendon is going to have a tears in future. And about Haglund's tubercle and the syndrome, where you have the inflammation of the Crigger's flight pad, and this Haglund's tubercle is going to cause irritation on the tendinochleus whenever there is movement of the flexor and dorsiflexion of the ankle. Once you have a tear, you have to try to describe the tear, whether it's a low-grade tear or high-grade tear, depending upon the 50% of the tendon thickness involved, or more than 50% of the tendon thickness is involved. And describe if it is confined to the medial one-third, or lateral one-third, or two compartments. Have a look at the plantaris tendon and its normal anomalies, and don't try to forget the proximal injuries, where we need to evaluate with an extended field of view on your ultrasound and also an extended field of view on your MRI. Once the tendinochleus is normal, but you have the clinical symptoms saying that the tendinochleus has the impairment, then try to evaluate the proximal injuries for the muscular tendinous junction injuries. Thanks for the opportunity. Thank you once again.
Thank you, Dr. Farah Prasad, for the wonderful presentation. Second speaker for this session is Dr. Gaurat Khan Sharma, currently Assistant Professor in Department of Radiology at Mahatma Gandhi Medical College and Hospital, Jaipur, India. Dr. Gaurat will bring you insight about role of ultrasound in cartilage imaging. Dr. Sharma, the time is yours.
Very good afternoon to everyone. I would like to thank the organizers for having me here and talk on this interesting topic to all of you. Today I'm going to talk about role of ultrasound in imaging of cartilage diseases and the role of interventions in their management. So what is the role of ultrasound? The role of ultrasound is mainly in the diagnosis and management of crystal deposition disease. Also, in cases of osteoarthritis, we can evaluate and actually quantify the extent of cartilage loss in many of the joints, as we will see in the future slides. And also, we can do a lot of ultrasound guided interventions, including arthrocentesis for aspiration of crystals and diagnosing which crystals they are. And also, a lot of ultrasound guided regenerative procedures can be done for treatment of osteoarthritis. So first, talking about crystal deposition disease, in our experience, we see a lot of patients with crystal deposition disease, sometimes as many as 5 to 6 a week. And a lot of these patients with crystal deposition disease, a lot of times go underdiagnosed, and they just keep suffering from pain, and often their MRI is being done, and inconclusive diagnosis made a lot of times. So the two most common types of crystal deposition disease are gout and CPPD. Gout is deposition of monosodium urate crystals, and CPPD is calcium pyrophosphate dihydrate. CPPD is sometimes not picked up on any other imaging than ultrasound, and for gout we can also do other imaging modalities like dual entity CT. But today we'll just stick to the role of ultrasound. Other less common types of crystals are BCP, basic calcium phosphate, TCP, tricalcium phosphate, and OCP is octacalcium phosphate. The two most important are being monosodium urate and CPPD. Now, two terms we should be very well aware of before moving forward and looking at the imaging. The two terms are DC sign, that is the double contour sign, which signifies chondrocalcinosis, that is deposition of crystals onto the superficial layer of the articular cartilage. And the second term is snowstorm appearance, that is the appearance we get on ultrasound when there is deposition of crystals within the joint recess. And also, we should be aware about optical microscopy with polarized filters, which is used to confirm whether it is CPPD crystals or sodium monosodium urate crystals. Now, what is the exact role of ultrasound imaging in diagnosis, management, and diagnosis of crystal arthropathy? The first and foremost important role is to confirm that it is crystal arthropathy and not inflammatory arthritis. So, very commonly we see in our practice that a lot of these patients who have actually crystal arthropathy have been treated for years for inflammatory arthritis, whereas all they have is CPPD a lot of times. So, first is to label that they do not have inflammatory arthritis, they have crystal deposition disease. Second, once we have established that there is a crystal deposition disease, second is to establish what is the degree of inflammation that currently the joint with the crystals has. And secondly, what is the extent of the damage caused by this crystal deposition disease? That a lot of times secondary osteoarthritis develops in setting of primary crystal deposition disease. And the third important role is to, if on imaging it is possible, to differentiate whether we are looking at sodium urate scan all of it from medial to lateral. And if there is a chondral defect, you can quantify the chondral defect, you can measure the transverse diameter of the chondral defect. If there is a osteochondral injury, you can, a lot of times you can see cortical irregularity. But low grade osteochondral injuries in which only there is a subchondral bone marrow edema, they will obviously not be picked up on ultrasound. This is normal cartilage imaging appearance of first MTP joint of foot. You can see the superficial layer is less echogenic than the deeper layer. So when this becomes more echogenic, this is known as DC sign. This is MCP joint, and you can see the normal cartilage overlying the head of metacarpal. This is a normal first carpometacarpal joint, a common site for osteoarthritis. So for diagnosis of this, we in our practice we do not do radiographs because ultrasound is good enough to quantify the degree of osteoarthritis and to decide further management. So here we can see this is the first CMC joint. This is the base of first metacarpal, and this is the first carpal bone. So you can actually measure the cartilage thickness. You can also look for any osteophytes if present. We will look at one case in the coming slides. We can also evaluate the fibrocartilage. As we saw the meniscus, we can see good 40% peripheral part of it. We can also evaluate the peripheral 50% of triangular fibrocartilage complex. So we can actually, this is TFCC, this is distal end of ulna, this is the carpal bone. So this entire, this structure, this entire echogenic triangular structure, this is TFCC. So this is the ulnar attachment of TFCC. So we look at TFCC for looking when we are looking for deposition of crystals of CPPD, or this is scaphoulonate ligament, the dorsal band of scaphoulonate ligament, another common site for deposition of crystals. So whenever we are imaging the patient for crystal arthropathies, we will always look at these sites, the images that we saw, the MTP joints, the MCP joints, TFCC, the dorsal band of scaphoulonate ligament, the trochlea, and the knee joint. A lot of time crystals can be present there also. This is just a nice image of articular cartilage overlying the capital and the radial head at the elbow joint. Now let's look at few cases in which we will try to look at different imaging features of crystal deposition disease. Now this was a patient who presented with severe pain in knee joint since past couple of months, and MR was done, and it just revealed some synovial hypertrophy and effusion within the knee joint. A definitive diagnosis could not be made. We did the ultrasound, and here you can see that the suprapatellar recess, there's a lot of synovial hypertrophy, and here you can see these echogenic crystals, the tiny echogenic crystals you can see here. This is all the synovium, and also you can see large crystals here. These are large crystals, within the suprapatellar joint recess. So these were not loose bodies; these were crystals. And on imaging here also you can see this is the lateral femoral condyle, and you can see that there is deposition of crystals onto the superficial surface along with some synovium over here. The same patient, when we image the trochlea, here you can see the normal trochlea image we have seen in the previous slides. Here we can see there is good amount of increase in ecogenicity of the superficial layer of the trochlea. The superficial layer of trochlea here has become equally ecogenic as the deeper layer, which signifies that there is deposition of crystals onto the superficial surface of the articular cartilage, signifying chondrocalcinosis. So this was a case of gout. We had aspirated the crystals. It was sent for microscopy, and monosodium urate crystals were confirmed. There's another case who presented with pain in on and off pain, cyclical pain uh, from time to time for the past 2 to 3 years. And on ultrasound, we found the patient had pain in both foot, both hands, and we did an ultrasound, and we found there was these decent sized crystals of around 3 to 4 mm within the calcaneocuboid joint. Another crystals in the dorsal recess of wrist. Here we can see the crystals. So this appearance, this is known as snowstorm appearance. So that is the presence of crystals, a cluster of crystals within the joint recess. These are known as snowstorm appearance. So this is the first MTP joint, and we can see crystals within the recess. Here we can again see crystals in the second MTP joint, and here we can see deposition of crystals onto the dorsal band of scapholunate ligament. This is the scapholunate ligament, and this is deposition of a decent sized crystal onto the dorsal band. Next, moving on to another case who presented with multi polyarticular pain, and here we can see that there is deposition of crystals. This is the fifth MCP joint, and here we can see there is deposition of crystals onto the superficial layer of the articular cartilage over here and here. You can see we had looked at the normal image of articular cartilage. The superficial layer will be very thin and uniformly ecogenic and less ecogenic. Here again we can see the deposition of crystals onto the superficial layer of articular cartilage. This is just a zoomed in image of the MCP joint. So this is the other hand MCP joint second digit, and we can again see the double contour sign signifying chondrocalcinosis. So DC sign is usually more sensitive for monosodium urate crystals for gout, but it is not definitive. If we see definite DC sign, we cannot definitely call it as gout. It is always better. It is confirmed either with biochemical correlation of increased uric acid levels, or when it is not 100% confirmatory, then we can do arthrosynthesis and evaluate the crystals in microscopy. So here again, another example of double contour sign, DC sign at the first MTP joint of left foot. This patient also had presence of subcutaneous nodules within the dorsum of the foot. So this was a case of gout, and these were gout-related nodules. So as we talked about that, sometimes it may not be 100% confirmatory that what crystal arthropathy are we dealing with. In those cases, we can put in a needle into the joint. So this is a short axis cine clip at the level of first MTP joint, and you can see the needle moving in below the extensor tendon. This is the extensor tendon. The needle is coming in plane, going below the extensor tendon, and we are trying to aspirate the crystal. We aspirate the crystal, and it was sent for microscopy. And here, this is just an image showing how CPPD crystals appear on polarized microscopy. So CPPD crystals will show positive birefringence, and the crystals will be rhombus shaped, whereas the sodium urate crystals will show negative birefringence, and the crystals will be needle shaped. These are needle shaped. Another case, here we can see this is the first CMC joint. As we looked at the normal CMC joint, if you try to recall that image here, we can see there is a very significant, obvious osteophyte formation in this first CMC joint. So this patient presented with pain over the base of the thumb, and this was a case of first CMC joint osteoarthritis. So whenever there is a cartilage loss, the bone responds by forming new bone, and that new bone formation appears as osteophytes. Sometimes these osteophytes get disconnected and they form loose bodies. So ultrasound is a great imaging modality to look at early osteoarthritis, wherein we can see the early osteophyte formation even earlier than radiographs. So this is a cine clip of the same patient, wherein this is the needle entering into the first CMC joint. So in our practice, we do a lot of PRP injections for CMC, first CMC osteoarthritis, and if the osteoarthritis is not very advanced, the results are significantly uh, great, and the patient morbidity and the pain decreases significantly over a period of time. It is obviously not curative if the osteoarthritis is advanced, but it can prolong the joint replacement for a very long time. And there are not many centers in our country, at least, who are doing first CMC joint replacement. So, a lot of times, if there is a substantial decrease in the pain of the patient, it is good enough. Just last few slides in which we are looking at more imaging, ultrasound imaging of osteoarthritis. So this is looking at medial tibiofemoral joint, and you can see there is a broad-based osteophyte formation along the medial femoral condyle, and here also you can see this is osteophyte formation. This is the medial patellofemoral joint, and here you can see there is osteophyte formation along the medial femoral condyle and also along the medial patellar facet. And you can actually even look at the articular cartilage. You can measure the articular cartilage slightly thinned out over here. Another image showing a zoomed in image of osteophytes formation along the medial tibiofemoral joint line, along with the horizontal tear of medial meniscus, the body of medial meniscus. So there is not a lot of literature on this, but we are just doing in our practice for research purpose, and the results so far have been quite collaborative. So we do a supine ultrasound scan of the patient to look for the osteoarthritis changes, and we measure the distance between the peripheral most part of the medial femoral and tibial condyles, and then we ask the patient to stand, and then we again measure the distance between the most peripheral part of the medial femoral tibial condyles. So here we can see on supine the same patient distance was 4.6 mm, and on standing the distance has become 3.7 mm. So we can actually also quantify that what is the degree of joint space narrowing. It is still a work under research, and hopefully if we have enough data in some time we'll be publishing it. Uh, Same patient, we can see this is the trochlear articular cartilage, and here we can see this is a cortical irregularity. Here we can see the lateral femoral condyle non-weight bearing surface, and here we can see the weight bearing surface of lateral femoral condyle. You can measure the weight bearing surface articular cartilage, it's 1.1 mm, and the non-weight bearing surface is 2.6 mm. So there is a moderate degree of weight bearing femoral articular cartilage loss over here. So for these patients with knee osteoarthritis, for grade 1 and grade 2 osteoarthritis, in fact, these regenerative procedures are the treatment of choice, along with good rehab and any kinetics correction if they have any. So we do a lot of PRP injections for these patients, and here we can see the needle is entering below the quadriceps tendon in short axis image. Once the needle is entered in short axis image, we confirm the needle position in the long axis image, and then we do the procedure. This is the PRP being injected into the joint. Case number 6, I will not go much deeper into this. I just want to highlight that ultrasound is a great imaging modality to look for and diagnose and treat medial patellar plica syndrome. So here we can see there's a significantly thickened medial patellar plica, which is measuring nearly 3.9 mm in thickness, as compared to normal side plica, which measures 2.5 mm in thickness. And you can also measure the articular cartilage, and we can treat these medial patellar plica syndrome under ultrasound guidance also. This is the MR image of the same patient. We can see the medial patellar plica. We can see the edema around it. I just wanted to show this case as what are the results with PRP injections in these cases of cartilage regeneration. So this was a case pre-procedure imaging has been done, and we can see there is a focal chondral loss involving the medial lateral patellar articular cartilage. The patient had significant anterior knee pain, and this is the ultrasound image of the same patient. We did a intra-articular PRP injections, 3 sittings for this patient, and we'll show the video for that too, and look at the post-procedure 6 months follow-up image. So this was the pre-procedure imaging, and look at how nicely the articular cartilage is formed and how the defect has completely filled up, and it's a good looking articular cartilage. So there is neo cartilage formation. This is a video of the same procedure. This is the needle tip into the articular cartilage. So we actually cause a little bit of microfracturing in the underlying subchondral bone. We inject a little bit of cartilage, intra cartilage PRP. We inject PRP around the cartilage, and we inject PRP into the joint. So here you can see the needle, and this is the PRP being injected out of plane technique. So in the end, I would like to conclude by saying that ultrasound is it should ideally be the first screening modality to diagnose crystal arthropathy, and a lot of times in CPPDs, ultrasound is the only imaging modality where you can see those tiny crystals. And even with that, you need a hockey stick probe a lot of times to visualize those tiny crystals into the small joints of hand and foot. Ultrasound guided regenerative injections for cartilage regeneration have excellent results, and in our personal experience, if the patient selection is right, if the PRP preparation is right, the results are really good if combined with a good rehab. And in our experience, ultrasound is far more sensitive than radiographs for diagnosis of early osteoarthritis, and medial patellar plica syndromes can be diagnosed and both treated using ultrasound guidance. I thank you all for your attention. I'll be happy to take any questions, if any. Thank you.
Thank you, Dr. Sarma, for your superb presentation. Participants can ask questions to the presenters through the chat box, and the presenter will submit their answer into the same chat box. Now let's welcome our third speaker. It is Dr. Adnan Sheikh, an associate professor of radiology at University of Ottawa, Canada. Dr. Sheikh will talk about acquired flat foot, what the radiologists need to know. Dr. Sheikh, the time is yours.
Good morning, everyone. My name is Adnan Sheikh. I'm from the University of British Columbia, and I'll be talking about flat foot deformities related to tibialis posterior tendon dysfunction. At the onset, I would like to thank the organizers, especially Dr. Paulo Cerrado, for inviting me to present at this year's AMS meeting. Posterior tibialis tendon dysfunction is the most common cause of acquired flat foot deformity in adults. Although the term flat foot suggests pathology involving only the tibialis posterior tendon, the disorder includes a spectrum of pathological changes involving associated tendons, ligaments, joint structures of the ankle, hindfoot, and midfoot. Early recognition of this condition is very key to prevent debilitating long-term consequences of this disorder. Without a functioning posterior tibial tendon, over time, the unopposed peroneus brevis tendon takes over, which is an antagonist to the tibialis posterior tendon, and it will pull the foot into a valgus and abducted position. That's why in patients with tibialis posterior tendon dysfunction, when viewing these patients from behind, the examiners will note that there is increased hindfoot valgus and the appearance of what is called the too many toe sign. I have no disclosures. Tibialis posterior tendon is more common in females, and there are certain predisposing factors like hypertension, obesity, and steroids. This is also common in patients with rheumatoid arthritis and those who have inflammatory arthropathies. And remember, most of these tears tend to be chronic in nature, secondary to repeated trauma and micro degeneration. And also, tendinosis and paratendinitis precedes the tear. The foot can be divided into two major parts, the medial and the lateral column. The talus, navicular, cuneiforms, and the first three rays forms the medial column, whereas the calcaneus, cuboid, and the lateral two rays form the lateral column. Conventionally, the lateral column is inherently stable, whereas the medial column has an adaptive function during weight bearing and acts as a stabilizer during the propulsive phase. Although the etiology of symptomatic adult flat foot is still variable, it is thought that it is due to abnormal repetitive load bearing of the medial column, which leads to attenuation and dysfunction of the tibialis posterior tendon. The medial column, in addition to the tibialis posterior tendon, is comprised of the spring ligament, the medial talonavicular capsule, the interosseous talocalcaneal ligament, the deltoid ligament, and the plantar fascia. The tibialis posterior tendon originates from the lateral aspect of the posterior upper tibia, and it runs along the medial malleolus and inserts to the base or to the medial aspect of the navicular bone. That's its main insertion. In addition to that, it gives out multiple slips to the cuneiforms, to the cuboid, second to fourth metatarsal bases, as well as the sustentaculum tali. These are the slips which, a nice diagram here showing the slip insertion to the various bones, which I mentioned now. The tibialis posterior tendon has a tendon sheath which terminates about 2 centimeters from the distal tibialis. The tibialis posterior tendon has a tendon sheath which ends about 2 centimeters from its insertion. The distal 1 to 2 centimeters of the tibialis posterior tendon, as well as the distal slips, are devoid of any tendon sheath. So if you see fluid in this area, it is pathological, and you call that paratendinitis. The mid portion of the tibialis posterior tendon is relatively hypovascular. A combination of ischemic and mechanical compression forces causes most tibialis posterior tendon disorders. Demographically, mid-tendon tears are more commonly seen in the elderly, whereas in younger athletic individuals, the tear is usually seen at the insertion to the navicular bone. In majority of the patients, the tibialis posterior tendon inserts directly to the medial aspect of the navicular bone, but there can be few variations. Sometimes you can see an accessory ossicle adjacent to the navicular bone. In this instances, if the ossicle is less than 5 millimeters, you call that type 1 navicular. And then in this cases, as in this case example I'm showing here, that tibialis posterior tendon engulfs the ossicle and inserts directly to the base of the medial aspect of the navicular bone. If the ossicle is larger than a centimeter, then you call that type 2 navicular. In this case, the tibialis posterior tendon inserts directly to this ossicle, and this is not uncommon to see pseudoarthrosis and inflammatory changes right at the synchondrosis there. The third type of ossicle is when of navicular is when the navicular completely fuses with the native navicular. Then you got this elongated medial process, and in this case, then again, this the tibialis posterior tendon inserts directly to this elongated medial navicular bone. Why is this important to know these different variations of the navicular? Because literature has shown that type 2 and type 3 navicular have higher incidence of tibialis posterior tendon dysfunction. The imaging modalities used to assess tibialis posterior tendon dysfunction. You start with your radiographs. You can do AP and lateral views. Ultrasound is a great modality in the right hand to assess for tibialis posterior tendon. You can do dynamic maneuvers, and also you can compare it to the contralateral side. MRI is a great modality to assess for soft tissue abnormalities. You can look for tendinosis, partial and full thickness tear, and also fluid within the tendon sheath. Plain radiographs are a great modality to assess for abnormal alignment and bony changes associated with long-standing tibialis posterior tendon dysfunction. These findings seen on radiographs help complement the soft tissue findings which you see on MRI. The most common imaging measurements which we do to assess for flat foot deformity are the talonavicular angle, first metatarsal angle, as well as the calcaneal pitch. So what happens when you have tibialis posterior tendon dysfunction? Again, you have valgus deformity and abduction of the forefoot. Normally, if you see the talus and the navicular articulation, the talus covers 80% of the navicular articulation. But in case of tibialis posterior tendon dysfunction, this relationship is lost because the abduction of the foot uncovers the talar head there. So the normal talonavicular angle is about 7 degrees, but in case of tibialis posterior tendon dysfunction, this angle is usually less than 7 degrees. The second thing you need to do is the first metatarsal angle. Normally, if you draw a line from the talus, it should bisect the navicular into two equal halves and extend to the first metatarsal. But in case of flat foot deformity, you have plantar flexion of the talus that results, in those cases, this line does not extend to that. The line from the talus does not extend to the first metatarsal, and the angle created by this first metatarsal angle is usually plantarwards by 4 degrees. So that is that is something to keep in mind. If you see an angle greater than 4 degrees, then you should call that pes planus deformity. The other thing you can measure is the calcaneal pitch. I think this is the most common thing which most radiologists measure. So you measure the angle between the fifth metatarsal and the calcaneus. Here you draw a line along the head of the fifth metatarsal to the calcaneus and the line along the plantar aspect of the calcaneus there. And this normal angle is about 18 to 20 degrees. If the angle is less than 18 degrees, you call that pes planus deformity. Ultrasound in the right hand is a great modality to assess for tibialis posterior tendon. Here you see the normal tibialis posterior tendon with its relation to the flexor digitorum and flexor hallucis. It has got a fibrillar pattern, a smooth appearance to it. You don't see any fluid surrounding the tendon. This is a normal appearance of a tibialis posterior tendon. The tibialis posterior tendon usually is double the size of the flexor digitorum tendon, which is normal. You can do dynamic maneuvers to look for any displacement. This is a case of an abnormal tibialis posterior tendon. Here you see the tendon is thickened and heterogeneous, and also you can see fluid and debris within the tendon sheath. And also you can put on color to look for any active inflammation in that area. MRI is a great modality to assess for tibialis posterior tendon dysfunction. As you know, MRI is a great modality to assess for soft tissue abnormality. The tibialis posterior tendon is usually seen posterior to the medial aspect of the tibia there. It is usually double the size of the flexor digitorum tendon or equal to the sum of the peroneal tendons. Here in the sagittal image, you can see the tibialis posterior tendon inserting to the navicular bone there. And here in the coronal, in the axial images more distally, you can see the insertion right to the medial aspect of the navicular bone. These are examples of the distal slips of the tibialis posterior tendon. Again, as I said, the main tendon attaches to the navicular bone, but it gives out distal slips to the cuneiform, cuboid, and also to the base of the second to fourth metatarsals. So if you see fluid surrounding these distal slips, that is abnormal, and that is usually abnormal, and we call that paratendinitis. As per MR, you can classify tendon abnormality into 3 types. Type 1 is partial tear, where you see tendon enlargement and nonchalant split tears. The second type is when you see thinning of the tendon, second to stretching and elongation resulting in because of a partial tear. And the third one is complete discontinuity secondary to a complete tear. So there are some primary and secondary signs on MR which can help you to assess for tibialis posterior tendon dysfunction. The primary signs are tendinosis, tenosynovitis, partial or full thickness tear, whereas the secondary signs, which we will which I will go through in detail in the upcoming slides. So this is an example of a grade 1 tibialis posterior tendon dysfunction. Here you can see the tibialis posterior tendon, which should be usually double the size of the adjacent flexor discorum tendon. In this case, it is about 4 times the size. In addition, you can see signal abnormality as well as split tearing within the tendon. And here, right at its insertion, again, it shows some increased signal there. This is a second type 2 tibialis posterior tendon dysfunction where the tendon is small in size because of partial tearing. And here you can see that the tibialis posterior tendon is almost equal to the flexor discorum tendon, and also more distally you can see increased signal and fluid within the tendon sheath. This is a case of full thickness tear. Here you can see the normal tendon should be located in this area, just posterior to the medial tibia there. So in this case, that area is the tendon is absent in this area, and more distally you can see the retracted. You can see that the more distal insertion of the tendon is also absent, and it is retracted. This is an example of fluid surrounding the distal slips of the tibialis posterior tendon. You can see here the distal insertion. There is tenosynovitis, and here along the distal slips you can see fluid surrounding the distal slips. So this is a case of paratendinitis. So what are the secondary signs of tibialis? The secondary signs of tibialis posterior tendon dysfunction, the first one is talonavicular fault. So normally when you draw a line from the talus, it should bisect the navicular into 2 equal halves. But in case of a tibialis posterior tendon dysfunction, there is plantar flexion of the talus. So in this case, the navicular bone is not divided into 2 equal halves. We already mentioned about unroofing of the navicular. Again, you can see this on radiograph. This is normally the 80% of the talus is covered with the navicular bone. Because of forefoot abduction, that relationship is lost, and that is called the unroofing of the talonavicular joint. The hindfoot valgus deformity, again, is very commonly associated with tibialis posterior tendon dysfunction. Here, when you draw a line, you measure the hindfoot valgus angle by drawing a line along the longitudinal axis of the tibia and along the medial calcaneus. The normal angle is greater than 6 degrees, but if the angle is more than that, then you call that hindfoot valgus deformity. Subfibular impingement, again, is very commonly seen with tibialis posterior tendon dysfunction. Normally, just adjacent to the fibula, you should see the calcaneofibular ligament and fat surrounding it. But because there is impingement between the fibula and the calcaneus there, that normal fat space is lost, and then you can see all that inflammatory changes in that area, and that is in keeping with subfibular impingement. The other thing you can see is a dislocation of the tibialis posterior tendon secondary to the tear of the medial retinaculum. And also, in some cases, we can see spurring along the medial aspect of that tibia, right where the tibialis posterior tendon resides. The traction of, you can get traction osteophytes in that area. So that's something, again, another thing to look for. So what are the other associated abnormalities associated with tibialis posterior tendon? The first one is spring ligament tear. Remember, spring ligament is an important stabilizer of the medial column of the ankle. So once the tibialis posterior tendon is torn, you can also get associated tibialis posterior, spring ligament tear. In this case, you can see on the coronal view complete tearing of the stretching and tearing of the superior medial aspect of the spring ligament complex. You can also get, if you see marrow edema right at the insertion site of the tibialis posterior tendon, again, that is a sign to suggest that there's inflammation going on. So there could be some associated partial tearing or a full thickness tear, which has resulted in this inflammatory change. Sinus tarsi, again, normally within the sinus tarsi, you should see fat and, the ligamentous structures there, but because there is plantar flexion, there is impingement of this fat and you can get inflammatory changes in this area resulting in sinus tarsi syndrome. The other thing, last thing, is plantar fasciitis. Again, plantar fascia is one of the important stabilizers there. So you can also get thickening of the plantar fascia, secondly to tibialis posterior tendon dysfunction. So in the last 15 minutes or so, we went through the basic, we went through the imaging modalities and imaging findings to detect tibialis posterior tendon dysfunction. Early recognition and treatment of tibialis posterior tendon disorder is key to prevention of debilitating and long-term consequences of this disorder. With that, I would like to say thank you for your attention and enjoy the rest of your conference. Thank you.
Thank you, Dr. Say, for your wonderful presentation. And now we are approaching the last scientific presentation for the first day of AMS meeting. Please welcome the last speaker, Dr. Sanjay Desai. He is an associate professor of radiology from Rajarsi Chhatrapati Shahu Maharaj Government Medical College, Kolhapur, India. Dr. Desai will conduct a lecture about MRE of ankle and hindfoot impingement. Dr. Desai, the time is yours.
Good afternoon, everyone. My topic of presentation today is imaging of ankle impingements. At the outset, I would like to thank the Asian Musculoskeletal Society for having invited me for this talk. The outline of my presentation is what exactly is impingement? Is the diagnosis of impingement really important? How to diagnose it? Classification and relevant anatomy. We'll see a few cases and then discuss the role of radiologist in the management and diagnosis of this condition. Impingement is a clinical syndrome of chronic pain, instability, and restricted range of movement caused by compression of abnormal bone or soft tissue within the joint. The pain occurs on performing specific movements or in load-bearing position or positions of stress. The exact cause of impingement could be due to a ligament injury or repetitive microtrauma at the extreme ranges of movement. Hemorrhage, reactive synovial hyperplasia, and scarring ultimately lead to abnormal soft tissue interposition and thereby causing pain in impingement. Which patients to expect? The patients who have a single event could have a malunited fracture, ligament sprains or tears, and post-traumatic synovitis, or recurrent events could be due to soccer players, runners, or ballet dancers who have repetitive ankle dorsiflexion and then resultant scarring. Other osseous causes could be developmental or acquired bony spurs, prominences, or presence of ossicles. The common sites of ankle impingement vary from posterior to posteromedial, anterolateral, anteromedial, and direct anterior impingement, which often coexist and occur in conjunction with other ankle pathologies. The diagnosis of impingement is mainly clinical, and supporting information is only provided by X-rays, CT, MR, and ultrasound. The X-rays show presence of bony spurring and osteophyte formation. However, they cannot completely diagnose impingement. For that, the MR would show soft tissue interposition and signs of impingement. Ankle impingement anatomically is classified into anterior, posterior, and extra-articular lateral hindfoot impingements. Anterior impingements could be anterolateral, anteromedial, or direct anterior, whereas the posterior impingements are usually posteromedial and direct posterior. The extra-articular causes could be talocalcaneal and subfibular, or what is called as calcaneofibular type of impingement. First of all, anterolateral impingement. These usually occur in young athletic patients following an inversion injury. For that, we have to understand what is the anterolateral gutter. The anterolateral gutter is a pyramidal space bounded medially by the tibia, laterally by the fibula, superiorly by the anterior inferior tibiofibular ligament, inferiorly by the calcaneofibular ligament, anteriorly by the anterior talofibular ligament and joint capsule. The causes of this impingement is ATFL tear and synovitis, thickening of the accessory fascicle of AITFL, which is called as the Bassett's ligament, presence of small ganglia, spurs or ossicles in the anterolateral tibial plafond, avulsed osseous fragments and syndesmotic ligament complex injuries, and sometimes osteochondral injuries to the anterolateral talar dome. The imaging findings, the most reliable sign is the obscuration of the anterolateral recess with scar tissue. Like in this case, we have a thickened anterior talofibular ligament and synovium, which leads to impingement. T1 weighted images are most useful for detecting the intermediate to low signal intensity hypertrophy and scarring in the anterolateral gutter. This is a T2 weighted image and this is a T1 weighted image. On stir images or T2 fat sat images, you also see there is thickening of this soft tissue and presence of impingement in this region. Same thing visualized in the coronal view. Anteromedial impingement is usually due to a supination or inversion injury, probably with a rotational component causing microtrauma and tearing of the anteromedial capsule and anterior band of the tibiotalar ligament or the deltoid ligament. There is capsular ligamentous and synovial hypertrophy and thickening, which can become compressed during dorsiflexion and inversion, thereby causing pain. Classic findings are hypertrophic spurs, reactive fibrosis, and synovial proliferation along the anteromedial gutter. The boundaries of the anteromedial gutter, superficially by the anteromedial joint capsule, laterally by the talar dome, body and neck, medially by the medial malleolus, and inferiorly by the anterior tibiotalar ligament or the portion of the deltoid ligament which is more anteriorly located. Anteromedial impingement on imaging looks like there is spurring and subchondral degenerative changes in the medial malleolus as well as talus, soft tissue thickening in the anteromedial region, in the region of the gutter. Same thing is visualized in the sagittal images and more so in the axial images. It is located along the anterolateral aspect of the tibial plafond. In this patient, you also see there is chronic thickening of the anterior tibiotalar ligament, which is scarred and thickened due to partial healing. This is another case in which you see there is spurring, reduced joint space between the medial malleolus and the lateral aspect of the talus, presence of marrow edema, irregular soft tissue thickening involving the anterior portion of the deltoid ligament. Same thing is visualized in the sagittal projection as well. Next, we have the direct anterior impingement that happens in the central portion of the ankle recess between the anterior tibial plafond and the talar dome with presence of spurring or osteophyte formation. The main cause for this spurring is direct repetitive microtrauma to the talus and tibia, thereby leading to formation of the irritation of the joint capsule, a synovial response, formation of fibrous bands which later ossify and form osseous spurs. There can also be tenosynovitis or ganglion cyst formation leading to anterior impingement. This is a case of direct anterior impingement in which you see there is bony spur formation along the antero-inferior aspect of the tibia, superior aspect of the talus with presence of mild marrow edema. Another case with similar changes of spurring as well as spurring from the tibia as well as the antero-superior aspect of the talus with soft tissue thickening and presence of marrow edema in the underlying bone. The same patient was seen on the radiographs as bony spurs, but this marrow edema and soft tissue thickening and interposition is visualized only on the MR. Next, we have the posteromedial impingement. It happens because of any soft tissue thickening in the posteromedial recess. This is the posteromedial recess, which is bounded anteriorly by the medial malleolus and the PTTL, or the posterior band of the tibiotalar ligament, laterally by the talar dome and posterior process of the talus, and peripherally by the joint capsule, neurovascular bundle, and the flexor hallucis longus tendon. The causes of this impingement is severe inversion injury. Deep fibers of the posterior tibiotalar ligament and posteromedial joint capsule become compressed between the medial wall of the talus and posterior margin of the medial malleolus. This leads to inadequate healing and fibrosis with formation of hypertrophic soft tissue, which may displace or encase the surrounding tendons of tibialis posterior and flexor digitorum longus, sometimes also extending up to the flexor hallucis longus. The findings on the MR are injured and thickened PTTL, associated synovitis, posteromedial joint capsule injury, presence of marrow edema in the affected bones. Flexor tendons are especially affected the tibialis posterior in 40% of the cases with presence of tenosynovitis or synovial sheath thickening. And the PD and T2 weighted sequences show loss of striations of the posterior tibiotalar ligament, also presence of capsular thickening and edema around the posteromedial tendons. This is a case of posteromedial impingement in which this is the lateral malleolus, this is the medial malleolus. We have the talus showing presence of marrow edema. There is overlying soft tissue thickening and presence of scarring, hypertrophy of the synovium over here. You also see there is hypertrophic scar tissue in this region with irregularity and marrow edema in the adjacent talar dome. There is fluid, and that is the tenosynovitis along these tendons. This is the flexor hallucis longus. This is the medial group of tendons. All these findings are seen in the posteromedial impingement. In another case, you see this marrow edema. You see the neurovascular bundle. The neurovascular bundle is immediately posteromedial to this region, and that is what leads to excessive pain in posteromedial impingement. Next, we have the direct posterior impingement. It happens because of activities that cause extreme plantar flexion, such as ballet dancers, soccer players, and downhill running. Two main proposed mechanisms are acute plantar hyperflexion injury or chronic repetitive microtrauma. The posterior soft tissues become secondarily hypertrophied and compressed between the posterior talus and the calcaneum. Sometimes there is presence of ostrigonum, which is commonly seen, or presence of a prominent steada process. A prominent steada process is an ostrigonum which has completely united with the posterior process of the talus. This increased compression leads to damage to the regional tendons and ligaments, including the flexor hallucis longus. The findings on the radiographs are either an ostrigonum or a steada process can be visualized, but the bone marrow edema, synovitis, thickening of the posterior ligaments, and the ganglia can be visualized on the MR in the form of soft tissue thickening in this region. This is just plain soft tissue thickening and edematous soft tissues around the posterior aspect of the tibiotalar joint. In this patient, you see there is an ostrigonum with pseudoarthrosis formation, marrow edema on both sides, presence of synovial effusion, and soft tissue thickening with mild edema. In this patient, you have excessive marrow edema in the talus as well as the superior aspect of the calcaneum. There is also soft tissue thickening and changes in the posterior aspect of the tibiotalar joint as seen in the previous study. The reason for this was when we did the CT, we found there is talocalcaneal coalition, and that leads to chronic degenerative changes in the joint between the calcaneum and the talus of the subtalar joint, posterior subtalar joint arthropathy, thereby leading to posterior ankle impingement. The differential diagnosis for posterior ankle impingement varies from Haglund syndrome to retrocalcaneal bursitis, Achilles paratendonitis, Achilles tendon partial or complete ruptures, and a prominent steada process. Sometimes we have mixed impingements in which multiple impingements come together in the same patient. This is mixed anteromedial, anterolateral, and hindfoot impingement syndromes. So this is soft tissue thickening along the anterolateral aspect over here. Then you have the posterolateral soft tissue we have anteromedial soft tissue, and also presence of hindfoot impingement in the form of subfibular impingement, which we will see later. So all these findings are there in the same patient. This was an operated case. So the operated case of calcaneal fracture and talar fracture leads to all of these impingements in the same patient. Next, we move on to extra-articular lateral hindfoot impingements. Either there is a talocalcaneal impingement or a subfibular impingement, which is kind of end stage for hindfoot impingement. Extra-articular lateral hindfoot impingement usually is a non-traumatic cause of impingement and presents as sequelae of pathological posterior tibial tendinopathy, which causes a flat foot and hindfoot valgus deformity. So this is the tibiocalcaneal angle, which increases in hindfoot impingement. Classification of lateral hindfoot impingement based on etiology is either primary lateral hindfoot impingement due to accessory anterolateral talar facet, or secondary or acquired because of exaggerated subtalar eversion owing to hindfoot valgus. Hindfoot valgus is primarily because of flat foot. Based on anatomy, we have two varieties, either the talocalcaneal impingement or subfibular impingement. Talocalcaneal impingement affects the lateral aspect of the talus and lateral aspect of the calcaneus with cystic changes and presence of sclerosis, whereas subfibular impingement results in bone marrow edema at the fibular tip and lateral calcaneus with formation of neocalcaneal facet, soft tissue thickening between the calcaneus and fibula with subsequent entrapment and thickening of the calcaneofibular ligament, and lastly peroneal tendon subluxation. Lateral hindfoot impingement can occur in rheumatoid arthritis. In this patient, we have the lateral portion of the talus and calcaneum showing degenerative changes, marrow edema, soft tissue thickening, thickening of the calcaneofibular ligament, and synovitis. Same thing in the sagittal projection. Sagittal images is showing the same marrow edema in the subtalar joint. Sometimes it can be post-traumatic. In this patient of ankle dislocation, we see that the healing has occurred, but there is significant degeneration in the lateral hindfoot, lateral aspect of the calcaneum, tibia, as well as the calcanea. Subfibular or calcaneofibular impingement occurs when the lateral hindfoot impingement further progresses, thereby increasing the hindfoot valgus. This valgus of the calcaneum leads to reduced space between the lateral malleolus and the calcaneum with subsequent impingement. So in this patient, we see that there is marrow edema in the talus as well as calcaneum. The calcaneum is significantly laterally present, that is the hindfoot valgus, and there is severe reduction in the space between the fibula or the lateral malleolus and the calcaneum, leading to calcaneofibular impingement. So to summarize, we have 5 types of impingement: the anterior, anteromedial, anterolateral, posterolateral, and direct posterior types of impingement in the ankle. To conclude, we must know the clinical history as to how this patient came about having the ankle pain, whether he has flat foot. That would be very important when we are evaluating lateral hindfoot impingement, or whether it is traumatic or chronic repetitive if it is the ankle type of impingement. We must know the anatomy well. Only dark signal in the ligament is not a signal of normality. The thickening of the ligament and adjacent soft tissues also should be evaluated for us to know whether the ATFL, for example, is partially torn, scarred, or is it normal. The adjacent fat around the ligaments and the neurovascular bundles also has to be normally visualized. If there is stranding, presence of edema on STIR or PD fat sat images, then it indicates the presence of scarring or abnormal edema. Next, we should check for associated pathologies, like for example, we saw a case of talocalcaneal coalition that can lead to impingement. Early diagnosis is important to prevent deformities of the foot, because ultimately, if it is diagnosed late, then there is no option but to fuse all the bones of the foot together, and that is very, very debilitating. So an early diagnosis would lead to change in modification and physiotherapy, which can prevent further damage, and progression of arthritis can be either halted or slowed down. We should always discuss the findings with the referring clinician when we are in doubt whether this is a case of a non-healing fracture or whether it is the fracture has healed and now we are seeing is impingement. Now that differentiation would come from a discussion with the referring clinician. A follow-up in these patients is essential to know if there is progression. MRI is a good modality for follow-up because it has no ionizing radiation and it should be followed with the same sequences that we have taken earlier on so that the follow-up is more beneficial and more informative. Early diagnosis and management of impingement is very important to prevent deformities and early progression to arthritis as well as debilitating diseases for which no further management exists. Further reading is suggested. If you have any doubts, you can mail or Instagram to me. I'll be helpful or I'll try to solve whatever doubts you have. Thanking you for your patient hearing. Thank you very much, AMS, for having invited me for this session.
Thank you, Dr. Desai, for your presentations. And dear participants, thank you for your active participation today and have a great rest for your day. Please visit our website, take a look at our supporting partner booths at your convenience time. See you tomorrow for second day of AMS meeting started at 8:40 West Indonesian or Bangkok time. I'm Dr. Shiani signing off. Good day all.
besok minggu depannya juga 2 hari. Rami yang MSK. Ada nggak punya duit? Udah, aku udah nggak inget apa. Tapi udah balik. Mana? Kabel apa? Ya, bukannya kita sebenarnya tuh lengkap cuma karena berantakan. Sebenarnya kalau dicari tuh ada. Aku sih kayaknya sih udah ya. Aku sih kayaknya sih udah ya. Ya kayaknya.